All right, so welcome everyone to the third day of the virtual annual summit of Mellencamp Mind and Machine Intelligence Initiative on Mind and Machine Intelligence. And I'm William Wang from Computer Science. Together with my colleague Miguel Eckstein, we co-direct UCSB's Mellencamp Initiative in Mind and Machine Intelligence. This is a cross-disciplinary effort to bring together UCSB's academics to understand the capabilities of human and artificial intelligence. So our goal is to design AI systems that is centered around fruitful interactions with human. And this initiative and today's event is made possible by the generous gift of Duncan and Suzanne Mellencamp. And as you know, this year, our summit has been focusing on the topic of AI and health. This is the third day of our event. For the first 2 days, we were focusing on AI and patients and also AI and radiology. And today we're gonna talk about AI and COVID-19. So for today's event, we will follow the format from the last 2 days. So there will be a 15-minute keynote that will start in just a minute. And then we'll have 3 20-minute guest lectures. And after the guest lectures, we will have a very short Q&A following each of the talk. But after the entire session, we will also have a moderated discussion at the end of today's session. And basically, we'll have a discussion with all of our speakers and our audience. So if you have any question, please use the Q&A function to ask your questions to a speaker at any time. Today's virtual summit is also co-sponsored by UCSB's Center for Responsible Machine Learning, Center for Information Technology and Society, UCSB Institute for Collaborative Biotechnologies, and Cottage Hospital. So let me introduce today's keynote speaker. Today's keynote speaker is Dr. Lynn Fitzgibbon. Dr. Lynn Fitzgibbon is a board-certified doctor in infectious disease and in internal medicine. She is the chair of the Division of Infectious Disease at Cottage Hospital. She's medical education director of research and quality, and she's also a clinical associate professor at USC. As many of you know, she's very familiar with our campus. We have 3 AI and COVID related events in the last 2 years. I think in the beginning of the pandemic, we were very lucky to have her telling us about the pandemic in our first AI and also COVID seminar in the summer of 2020. And then later, we're also very happy to have her back to speaking at our CRML event on the development of the pandemic and related developments in this area. So today we're very happy to have her back to our campus virtually and to talk about her understandings about AI and COVID-19 vaccination. So she will talk about how to harness the power and avoiding the pitfalls. So with all that, I want to have Lynn to take over the floor, and please go ahead. Welcome.
Thank you very much, William, and to all the organizers. It's a pleasure to be here. Let me go ahead and share my screen, get myself set up here, and perhaps just ask for a verification from somebody that we're good. Okay, perfect. Thank you. So again, my affiliations, as William mentioned here, just jumping right into it, no financial disclosures, but I couldn't pass this slide without admitting my true disclosure is I'm just a physician, just a clinician. And so really, I think the conversation we're going to have right now, I just ask you to keep that in mind. I think there are so many places where the clinical world, the computer science world, the basic science virology world, the epidemiology world, so many places where those Venn diagrams this year have intersected in a way that's been incredibly fruitful, productive, and I think has set a stage for years and hopefully decades to come. But again, keep in mind that I am a stethoscope wearer. So as I mentioned, I'm really speaking to you today as a clinician. I've worn several hats over the past 18 months, taken on several roles, but my main job continues to be that of an infectious disease physician. As William mentioned, also primarily a clinical educator working with resident training doctors, medical students. And it's through that role that I really care for most of the patients I see with infectious diseases. There have been many, many lessons and takeaways this year for all of us, some clearly quite profound and some actually far more practical. And I've been reminded, I think, again and again, day over day, really hour over hour, of the importance of really seeking what I think many of us strive to seek, which is truths based on solid scientific principles. This last 18 months has given us example after example where very reasonable people looking at a problem or a case from different angles have seen things differently. And I think it's been a challenge for all of us on the clinical side of the street to lean far more heavily on tech than ever before. And also to, I think, increasingly have to make judgment calls when there has not been solid clinical or scientific evidence to support the decisions we've been making for the person in front of us. I've continued to be reminded, though, that there's been something very fundamental about the experience this year compared, for example, to 100 years ago. And we've heard this over and over again. This conversation is not a new one. But just, I think, to remind everyone, when we consider the doctor-patient interaction, we're reminded, I think, that what I went through, what many of our colleagues went through this year, has really been so very fundamental to that, patient and healthcare provider interaction that has so many similarities compared to 100 years ago. Clearly, a respiratory virus causing this worldwide pandemic, big surges, ebbs and flows, healthcare system strains like no other, congregate settings disproportionately impacted, whether we're talking about skilled nursing facilities, congregate homes, or of course our corrections facilities, just to name a few. But thinking more specifically about my experience this year, the similarities that I had to that of a clinician from 1918, I would have likely worked in a ward with much the same infection control principles. We cohorted patients just as was done 100 years ago. This is a tried and true approach, one that's changed little over 100 years. And just as my predecessors understood, I too have been wearing a mask as I stood over the bed of patients really all year. Ultimately, the cornerstone for so much of our clinical care also has not changed. This is a disease, as yet, without a clear cure. And really, so much of what we are doing for the patients in the hospital building that I'm giving this lecture from is supportive care. It's supporting people's breathing with extra oxygen when there's so much inflammation in their alveoli or air sacs of their lungs that they can't efficiently get oxygen into their bloodstream. We support people's blood pressure with fluids, with vasoconstrictive medications. And while it's absolutely true that we've leaned on antiviral medications, immune modulating treatments, and therapeutic monoclonal antibodies, it's really at the core of it so very similar to the experience from 1918. And while there's certainly been no shortage of tragedy anywhere, time and again, what we continue to see even this week is that it's the countries, the regions, the areas that run out of the ability to give that supportive care that are hit so very hard with those rising death rates. And so then, after reviewing so many of these similarities between 1918 and the current pandemic, it's clear to all of us, of course, that there is a set of differences in stark contrast to the experience of 1918. And I think as I considered this talk, I realized that it is fundamentally those differences that I think are the backdrop for for the ongoing conversation here. The tech era has given us so many opportunities that, again, were perhaps even unthinkable 10 years ago, let alone 100 years ago. We've had rapid clinical communications. As my colleagues who do what I do in Northern Italy last March were experiencing what they experienced, I had real-time information relating to that experience, what was working, what was not working. My critical care colleagues had the same. What lung protocols for the ventilators seemed to be working better, what were not working better. Again, the rapidity of these direct clinical communications, as well as, and there's a lot, this is a whole conversation, but pre-publication data dissemination, while certainly not without its flaws, has really been a huge cornerstone in the way that we get information quickly and rapidly in an era where that has been really important. Virtual connectivity within a healthcare system. And what I mean by that, again, these patients sitting in our hospital today have access to an iPad, have access to their healthcare providers, perhaps, many directly, but some perhaps the social worker connecting to them indirectly through FaceTime or other virtual connectivity. In addition, between healthcare systems, our connection between our hospital and other hospitals, of course, relying very heavily on that. And then data sharing at every level, critically important. The speed, we'll talk a lot about this, of clinical trial advances, as well as the capability of vaccines and therapeutics. And then the genomic level epidemiology that has simply exploded, looking at the genes, looking at the specific mutations and substitutions that are happening on a genomic level, and using that for both surveillance and epidemiology, especially in what I would say is the era of variants of concern. We now, of course, have the WHO, the European CDC, the UK, and of course, the CDC here in the United States, as well as many other national and international healthcare agencies, classifying new variants as either a variant of interest, concern, or in theory of high consequence, being the worst case scenario for which there has been a set of criteria established, but thankfully, as I give this talk, not yet a variant of high consequence identified or developed. And then finally, predictive modeling and machine learning tools to help us with many aspects of the pandemic, a critical tool, and one that we're really going to talk about for this next 30, 40 minutes. And this includes forecasting of the surges that we've seen, healthcare capacity challenges, how to anticipate, how to forecast, how to predict, and how to prepare for. And then really, of course, the focus for the rest of this hour, vaccine efforts. So as we reflect on COVID-19 and the impact that AI and machine learning has had on the entire COVID-19 vaccine effort, I think it's important to pause and review where we are with the COVID-19 pandemic here in June of 2021. Never before has data been so critically important, but never, of course, has data in every sense of the word been so public facing, so readily available to really every consumer of data. I'm going to buzz through a few example slides from just one day, 2 days ago, earlier this week, out of one media source. And again, there are many. But here we see the New York Times summary of daily new cases globally from the beginning of the pandemic until this week. The curve is rich with data. Many of us remember every single little bump, ebb and flow in this, with both discrete and some interlinked surges occurring around the world. There have, of course, been notable drivers of this curve, including surges in the US, Europe, elsewhere last early summer, late spring, Brazil in later 2020 with the recognition of the P1 variant and its tendency for immune escape, causing reinfections in regions that had previously been hit. And now, of course, the devastating surge most recently in the Indian subcontinent of a magnitude such that it really affected in a quite dramatic way the global data, as you see here, really from April and into May. And yet, of course, this week, more hotspots now developing across South America, as well as other places in Southeast Asia, including Vietnam this week. Along with these daily headlines regarding case counts have been the remarkable news that we are approaching 2 billion doses of vaccines administered worldwide, and we'll definitely come back to this. The data is really everywhere and it is rich. Here we have just one of the countless examples. Again, this is from the New York Times a couple of days ago, where the user can very quickly toggle through hotspots on this map, specifically looking at average daily cases over the past week, and then switch to total cases, an aggregate tally from the beginning of the epidemic. And then toggle straight to deaths, where we get a glimpse of the geographic distribution of mortality across the world and the magnitude of those region or country's mortality. And finally, we can look not at aggregate tallies, but at cases per capita, again, case rates. Each of these topics deserves far more than a slide, and we could dive into the heterogeneity we've experienced with factors such as diagnostic testing and other factors that really impact so much of this data, as well as other inequities around the world. I think suffice to say, this has been a long and very complex 18 months. The data has touched us all and in many different ways. And as I mentioned, this is just one of the many media, government, non-government data services available to track cases, case rates, and deaths. So piggybacking off this evolving landscape of direct to public rich data streams for EPI has, of course, in parallel come this huge explosion of vaccine-specific data. Indeed, since the first vaccine was approved here in the United States in the middle of December last year, the interest and analyses of the vaccine-specific data has really exploded. We have countless trackers to measure global, national, and local vaccine information. We have the ability to analyze administration rates, percentage of the population covered by the vaccine. Here we see broken down by those who are partially vaccinated, those who are fully vaccinated. And again, we can look at the whole population, including those under the age of 12, with perhaps some link to the question of herd immunity. Or we can look at really how well are we doing for all who are currently able to get the vaccine. And here in the US, of course, that's ages 12 and up, with about 49% now fully vaccinated. Again, countless trackers like this, but the data is there and it is in excess, I would say. And another example, we can see here very quickly the breadth of the state level data with a quick glance at every state and region, showing us whether or not that state is above or below the national vaccine rates. And again, just to, I think, highlight the efforts and I think the explosion of the field of data science in the consumer facing realm. Here we have, not just, relative to the median or to the mean, but also, over time and how these trends have changed. Again, a huge amount of data just there for the consumer. And finally, we can break down the data by vaccine manufacturer. In each of these charts, we see so many individual parts of the story. In this one example, we see the effect that the J&J pause had, as what you saw was starting to be an acceleration in the Janssen vaccine, a single dose vaccine, very attractive for a lot of reasons, viral vector, not mRNA. And what we saw was that slight uptick starting and then of course the effect of the pause related to some a rare but significant adverse event that was being studied. And then finally, at the far right, you see, a very small tick up. Perhaps this is an effect. We see it mostly with the Pfizer vaccine of the 12 and up now being authorized here in the US. But Moderna did it too, and Moderna's age hasn't dropped. So, is this indeed part of the new effort with vaccine incentives being offered around the US in recent weeks? Again, just an example of I think the extent of the data that is just so readily available. And finally, this graphic, I think, for me symbolizes just, the efforts of our data scientists as they are trying to tell stories. And this, I think, is one of the more creative and powerful ways that that story is being told. And indeed, one of my favorites. So follow me. Just if some may have seen this, some may not have. But each circle represents a county in the US with the size of the circle demonstrating the size of their respective populations and the color of the circle indicating what region of the US the county is in. The counties are then broken down by thirds, ranked by what's called their social vulnerability index, which is an indicator used by the CDC to really determine which counties are the most vulnerable or the least vulnerable based on socioeconomic status, housing, transportation, race, ethnicity, language. And then what you have along the top is the most vulnerable counties, and along the bottom, the least vulnerable counties, and the middle tertile in the middle there. And then from left to right, each of these counties is then put in the location that correlates with their vaccine percentage, their vaccine uptake, 10% on the left, 50% on the right. And so the trend clearly depicted here is that the most socially vulnerable counties are experiencing, sadly, the lowest vaccination rates. And the least socially vulnerable counties are experiencing the highest vaccine rates. Vaccine inequity, as we're going to talk about related to machine learning, really at every level, locally, nationally, and globally, is a tremendous opportunity. And again, we'll touch on it more later. For now, I just wanted to, I think, show this graphic as yet another and perhaps final reminder of the wealth of direct-to-consumer data science that is just increasingly available and so very powerful. And just as we also, I think, think about what our public, what our consumers have been increasingly exposed to, and by consumers I actually include us clinicians in this. I think we're reminded that predictive modeling has really become part of our everyday lives. Complex charts like this one telling the tale of not just one predictive model, but an array of projections based on dynamic vaccine rates calculated each day since February 1st. Again, this is just one of many, but a reminder that the extent of this data, predictive modeling, and ultimately the tools that come from this related to machine learning have really been thrown to the forefront of our clinical worlds and indeed the public. So as we consider the expansive data landscape that exists, we see clearly many of the opportunities for advanced data-driven decision-making and support. And much of this linked directly to machine learning approaches. Since early in the COVID-19 pandemic, prediction and tracking has really led the way. Indeed, there have been several predictive modelers themselves who have become household names, and many models and institutions similarly talked about really in the lay press and around town. Present in front page media headlines since February, March of last year. The media, I think, increasingly became comfortable leaning on some of the sophisticated projections that came forth from this work. In another example, thankfully, the days of public health nurses walking around with clipboards and asking people where they have been and who they have been with may thankfully be a thing of the past as we increasingly move towards tech-based contact tracing for cases of communicable diseases. Bluetooth, other proximity-based machine learning algorithms have been rolled out with variable uptake and adoption around the world. And while there continue to be important discussions surrounding privacy, confidentiality, and reliance on the population level uptake for optimal use, leveraging these machine learning algorithms in such a way as to better assess risk of exposure to an infectious disease is increasingly understood by ID physicians, my colleagues, certainly, as I think the way of the future. We simply can't rely on the nurse with the clipboard. We must do something more sophisticated if we want to be most effective. Monitoring for cases of an epidemic infectious disease is now increasingly feasible as we lean on ML and AI for individual level mobility data. But also, when we think about migration of infected or potentially infected persons, the importance of the geography of health comes forth. This includes, of course, leveraging data in the form of perhaps GIS mapping, case data. And this, I think, opens the door for monitoring case dynamics over space and time in ways that we've never seen before. Early diagnosis and clinical management are really important aspects of ML applications for the future. As we learned about yesterday and throughout this week, the opportunities really abound for us to use machine learning algorithms for decision support for clinicians, radiologists, and others. They're not infallible, and many of the bias types that we study and strive to avoid in my world in academic and clinical medicine can be avoided or greatly reduced when we as clinicians get support from algorithms based on, of course, these data-driven processes. The ML algorithm, when it sees ground glass in the lungs on a CT scan with certain density, is, as you all know well, far less likely to be influenced by the case that it saw yesterday. Despite my best efforts to avoid these cognitive biases, I own them. I know that they are part of my practice. I try to avoid them, try to educate my resident physicians to look out for them and recognize them. But really, we as clinicians, I think, remain very, very vulnerable to this. When we think about protein structure predictions and development of therapeutics, this, of course, has moved faster than ever before, as data sets from genomic level information of viral protein structures are considered alongside data sets for both novel but also historic drug libraries. Models have been developed by several groups around the world to take novel therapeutic agents, but also historic therapeutic agents, without having to go through the effort of even phase 1 clinical trials or phase 2 clinical trials, really jump ahead to use more sophisticated ML algorithms to pick and choose the targets that are most likely to be of highest yield. And then in remarkable parallel to the ML applications for non-medical information dissemination has come our ability to use and harness the power of machine learning to most effectively distribute and efficiently target information. The paper flyer in the mailbox, just like the public health nurse with the clipboard, are inexact. And so to replace these by more efficient, effective, but ultimately far more powerful machine learning guided techniques for information distribution has, of course, exploded. Closest to my world in recent months has been the fast-paced application of genomic level sequencing to track the epi of several primary variants of concern. And although AI-based techniques, including metadata applications, are in their infancy, I have colleagues, and I'm part of this, who really argue that epidemiology will never be the same again. When we have a cluster, let's say in the last month, a cluster of COVID-19 within a youth sports team, and we're trying to figure out, really how this cluster began and understand the potential for this cluster expanding, knowing that they came from a common source as opposed to multiple entries within that population is so critically important. And the fact that the genes don't lie and the genes will tell us that, I think, again, infectious disease will never go back. And all of this before I even mention vaccines, which is what I'm here to talk about. So machine learning, artificial intelligence played very powerful, absolutely critical roles in the vaccine efforts, as we'll talk about. And the question, I think, is not whether these approaches have been life-saving, but some ask whether the life-saving effect should be measured in the thousands, perhaps tens, or even hundreds of millions of lives saved by this. Again, just to pause and reflect on 1918. So as we consider the impacts of AI on COVID-19 vaccine development, I think we have to remember that therapeutic development has a rich history with AI, and many of you are deep in this and do this. It's also important to remember that conventional vaccine development, the way that we've done it for decades, has been so very costly and based primarily on traditional micro techniques, often bacterial culture based, painstaking, pipetting, and really bench lab work, as opposed to getting the jump start that we can by using and leveraging the ML applications and algorithms to really help focus us even in the preclinical trial period. And so along those lines, increasingly vaccine development has been based on what's called reverse vaccinology, first developed about 30 years ago, and based on taking the genome of a pathogen. In our case, we're talking about a virus as a pathogen, but taking the genome and using that genome to help design vaccine. It's been the foundation for RV prediction programs where genomic sequences have been used to predict epitopes and vaccine targets in a way that simply wasn't feasible before high-speed processing and protein structure prediction algorithms were well established. And it's not just the prediction of the protein structure, but of course, the prediction of the interaction with the human host cell, with the human antibody, with the human T cells. And it's none of this is binary. And the ability to, again, use ML, lean on ML with so much granularity, detail, and then predictive anticipation and reasoning, take this to, again, help guide the vaccine development process has been nothing short of extraordinary. AI has, of course, enabled the creation of models that learn and then generalize patterns using the available data, but also, as we mentioned, as yet unseen data, and using these predictions, as we mentioned, related to perhaps variants at a very specific but seemingly important mutation or substitution level, and then applying these methodologies to better equip the vaccine developers for what may be ahead. Making sure that, again, any critical substitution, as we're experiencing with the E484K with some of our variants of concern, or the L452R with some of our other variants of concern, thinking about ways that, again, vaccine development can keep up and leaning on these techniques. This is just a quick reminder. I kind of flew through some of the basic immunology, and I'm not going to spend much time on it because I really want to focus on some additional topics. But just to remind everyone, what we really are looking for when we're developing vaccine is, here we have the virus and the human cell. And what we're really looking for is ways to develop antibodies primarily, but also other immune responses that are going to target this spike protein. And it's this spike protein that's encoded by the S part of the genome, the viral genome. Small mutations in this spike protein confer the ability to evade this antibody, or perhaps have less affinity for it. And again, I mentioned P1 already out of Brazil, now up to about 15% prevalence here in the state of California, where I'm giving this talk. But again, these subtle differences with, for example, the E484K mutation, to be able to use machine learning to predict changes and substitutions in the viral genome in a way that gets us ahead and not behind of the predictive immune attack responses, the immune approaches, and indeed fundamentally vaccine approaches, has been so very important. I'm going to mention a couple of papers. This one is, I think, just a good and important example. Came out in July of last year. I think a group out of the University of Michigan. And again, this is just an example of the reverse vaccinology approach using bioinformatics and based on the pathogen viral genome to help predict which proteins would be the best targets for vaccines. There had been a lot of focus already on the spike protein, but this group, through the ML technique that they used, were able to determine that other specific proteins or parts of the protein were really good and important targets going forward. I think an important part, again, especially in the clinical world, that I was so reassured about was not only did the ML algorithm have the ability to look for and determine good targets, but they also were able to deliberately look for targets that may be autoimmune inducers. And what I mean by that is one of the biggest adverse effects that we always look for with vaccines, and have had experience for with other vaccines certainly, is the idea that while we can give a vaccine and it can train our immune system to fight a pathogen, one of the concerns is always that in a small percentage of people, we may turn on someone's immune system against their own body or against part of their body. And so again, to be able to not use pipetting techniques and microbiology in a lab, but actually in a sophisticated way say, this protein could be a good vaccine target, but it looks a lot like these human proteins, or it has a tendency based on the sequence to actually perhaps increase the risk of an autoimmune reaction or an autoimmune adverse reaction side effect. The ability to do that is, again, I'm short of adjectives to really emphasize just how important and powerful that is. and that it gets us, I would say, 2 or 3 steps ahead of the clinical trial process, just by simply being able to do that. Vaccine development has been advanced, as we've mentioned, by machine learning. We have the viral protein sequences, which can be used to predict the potential epitopes. Predictions of not just the epitopes, but also thinking on the host side at the receptor binding domain of antibodies and T cell receptors. And also, again, I mentioned this briefly earlier, but also looking at the binding affinity. Again, regarding that as not binary, that has variability, and regarding that in the algorithms, very important. Simulations have used the variant spike proteins, as I mentioned, from new and evolving variants of concern, variants of interest, protein interactions, and then also considering both primary and secondary protein structures. Remember that protein structures are themselves quite dynamic and fluid. They change in configuration when an antibody attaches or when they bind to the ACE2 receptor of the host cell. And so again, considering all of these factors has been very important. Spike protein continues to be the primary target of all of the current vaccines on the market. But through the machine learning approaches, other potential epitope candidates can be efficiently and have been vigorously investigated. Another example of the preclinical trial potential of AI, this group, I think out of Norway and Germany, used AI to basically predict blueprints for designing universal vaccines against SARS-CoV-2, again, with the idea of using the proteome and considering also human population HLA alleles, and looking at host cell infected surface antigen presentation. And again, this idea that these proteins on the host cell and on the virus do change in configuration. And then looking for parts of those proteins or epitope hotspot regions, which are more likely to be immunogenic or give an immune response across a broad spectrum of HLA types. So from my perspective in the clinic and the hospital, one of the most tangible examples that I've felt has been the clinical trial impacts of AI and ML. Everything I've talked to up till now, quite frankly, is the parallel to AI and ML is the virology bench. And I don't live or work in the virology bench. I certainly appreciate the virology bench. I collaborate with virologists at the university. But my world is the clinic, my world is the hospital. And so where I felt just tremendous benefit is again in what happened with our vaccine clinical trials. This is a quick description that we've heard about a lot. This one's from the Johns Hopkins Coronavirus Resource Center, where we see a typical vaccine development timeline. And we've heard this quoted over and over again, years. It takes years to get a vaccine to market. And this was indeed the case. This has been indeed the case. Remember, this is because every clinical trial phase gets completed, and then the next clinical trial goes on, and then manufacturing scaled up, and after the phase 3 clinical trial, an approval is completed. And one of the concerns I hear every day is, I'm not comfortable, doc. I'm not comfortable getting this vaccine because it went so very fast. And vaccines are supposed to take 10 years. This went too fast. I can't trust it. And so remember that in the pandemic, we've had this accelerated timeline where some of the clinical trial phases were combined, but the cases accumulated rapidly because there were a lot of cases, so a lot of ongoing exposure. And then there's been investment in the manufacturing acceleration and capacity, scaling that up with support of government agencies to again help the pharmaceutical industry invest and commit, even with perhaps some financial risk. And so when we look at this as an accelerated timeline, again, we have the preclinical trials, which we've already talked about. Again, pipettes and the pipettes and very basic virology historically with bacterial cultures. No longer the case. We were able to leverage AI and ML techniques. And then we have the phase 1 clinical trials, the phase 2 clinical trials, and then the critical phase 3 clinical trials, where we're no longer looking at simply do people tolerate it and what side effects do they have, but actually in phase 3, do they have benefit? And it's in these phase 3 clinical trials that I think is the untold story of the use of ML. Because the pandemic was raging, because the pandemic was continuing, as these vaccines became available and became ready to start phase 3 clinical trials, the key was then to give it to people, give the vaccine to people and then give the placebo to people, and then to see after a small number of weeks or months who developed COVID. And remember, a large part of the reason it used to take us 10 years to get good data is that we didn't reliably know that people could continue to be naturally exposed to whatever infection we were trying to protect them against. And while I say that the pandemic was raging, remember the pandemic was not raging in a homogeneous way everywhere. And so what indeed was used, and this was a particularly famous example in a collaboration between the an MIT group and the Janssen group for J&J, was ML techniques. It was basically by leaning on the predictive modeling with machine learning to identify clinical trial sites where there was anticipated to be a hotspot, that the clinical trial sites were chosen. And so the group basically developed a model called Delphi, which some of you may be familiar with. And it's based on a standard SEIR model. And they basically used this model and then looked at a variety of other factors, including the current effect of the pandemic, length of time for those who were recovering from COVID, how long they were likely infectious, who died and were unlikely to pass it on to other people. But ultimately, by using this technique in the spring, summer of last year, they were able to roll out the clinical trial, the phase 3 clinical trial for the Johnson & Johnson or Janssen vaccine in locations where there was still going to be a high level of exposure, so that as they compared those who got the vaccine to those who didn't get the vaccine, a small number of weeks or months later, they were going to very quickly see a difference if indeed there was one. And again, if they had done this without this approach, or if we had to do this and simply roll out a vaccine today in, for example, California, where the rates are thankfully dropping quite substantially, it would now take us months or years to enroll enough people to see that delta where we would be able to demonstrate benefit. So again, on a very practical level, I think this is perhaps the most tangible example to me where ML directly impacted our ability to get the vaccine out. As we mentioned earlier, the timing of this talk is perhaps best suited to the conversation surrounding equitable access to vaccines. And here we see, again, critical opportunity for data-driven, adaptable models to improve access and vaccine rates. AI models have been used for critical needs assessment, both within and across regions and countries, as well as more granular needs within communities themselves, including very specific interventions such as addressing vaccine hesitancy. As a separate but related problem, addressing the inefficiencies and weaknesses across supply chains, procurement processes, delivery logistics, traceability or storage. These are all barriers to vaccine administration, but the details and extent of these barriers are highly variable location to location, and also temporally. What's a barrier 1 month may be different the next month. And finally, the healthcare economic impact of the vaccine distribution and administration itself is, of course, an important factor as both government and NGO agencies look to improve vaccine rates. Using financially focused algorithms, which we've of course had for many, many years in business and the finance sectors, and using these to understand market assessments and opportunities has been crucial for these companies as they, on every level, from the big names themselves that are making the vaccines to everyone involved with infrastructure, to be able to more confidently and sustainably participate in vaccine rollout efforts. And all of this, I think, ultimately impacts what's going to happen from here. One interesting example was Advent Health in Florida, who have a history of using AI within their 50+ hospital system for a variety of reasons. But what they did is they actually use this to pinpoint the reasons that their patients were vaccine hesitant. And they used a digital survey platform last October to ask patients about the likelihood of them getting the COVID vaccine once it's available. And they then applied machine learning and natural language processing capabilities to the verbatim responses from the patients. And then using that, they said that they gained more detailed insight into the demographic groups that were displaying hesitancy, certain race, ethnicity, certain socioeconomic, certain geographies, again, a huge system, 50 plus hospitals, so different locations throughout their system. And then once they understood the reasons or perhaps the factors impacting vaccine hesitancy, it empowered them, it informed them, and it gave them the ability to then target vaccine outreach information and access to those who were indeed vaccine hesitant. So perhaps more on the, I would say, social science aspect of AI tech applications, but again, so very powerful, so very important. And finally, integrating the predictive modeling we discussed with vaccine efforts themselves. We have the opportunity to use ML to improve our forecasting, distribution, quality assurance, and adverse event surveillance. We can use AI to figure out where we need to be sending the vaccine, how to avoid disruptions and blockages. Quality assurance is an ongoing problem when we're talking about mRNA vaccines, the Pfizer biotech and Moderna vaccines, these of course must really be kept in ultra cold storage for the majority of their time. Increasingly, we're liberalizing how long they can then be at a refrigerator temperature or room temperature, but still to roll this vaccine effort out through the developing world with a vaccine that fundamentally needs to be kept at a very cold temperature has logistical challenges. And again, leaning on tech essentially, and leaning on ML algorithms, leaning on supply chain assessments in a way that's sophisticated and dynamic has been, of course, critically important. And then I'll mention briefly event surveillance. Here in the United States, we have a system in place for all vaccine adverse event reporting. And again, this is more sophisticated than ever. We then rely on the output coming from our CDC or from other academic research groups to report the adverse event trends or news and information. But I think another good example of a rich data source that is hopefully in the future going to get more and more effort related to sophisticated algorithmic approach to understand, again, on the clinical side, how we need to be advising patients. And then just coming to the end here, while there are many, many players involved, and again, I'm a clinician, so I apologize to many groups that I'm not highlighting today. But as I researched kind of for this conversation, I did read about IBM over and over again, and their efforts to accurately forecast the demand for the vaccine, seemingly quite crucial, particularly given, again, the ultra cold temperature necessary, and the absolute imperative to avoid waste. We cannot, risk wasting this, as we continue to have, vulnerable people around the world as yet unprotected. And so IBM has been among the companies to work with US hospitals, state governments, and manage much of the early initial supplies of vaccines using what I understand is Watson Health Analytics software, zip code level data, and as well as people's attitudes towards vaccinations to try to anticipate, predict, forecast vaccine demand and make sure that the vaccines are distributed equitably. Just another comment on that one. And then macro-wise, I'll mention two. Another company, this one has a history of AI related to vaccine rollout in Sierra Leone, actually last year, unrelated to COVID, but more recently with Stanford University, with a focus on no-shows and trying to, again, understand why patients may have an appointment but don't show up. And so this collaboration built a system that could reliably predict which patients were likely to miss appointments and then suggest alternate times, clinical locations that would increase the odds that the patient would actually show up. Other partnerships, including with the Gates Foundation and several African countries, really a focus on health-seeking behaviors. And so I think my perspective as I read through 2 or 3 descriptions of this is that the Macroize AI software looks at data sets, including geospatial, satellite imagery, information from mobile phone users in a given area, government healthcare systems, and social media posts, putting it all together to, again, try to anticipate vaccine demand, but also specifically health-seeking behaviors. So just to finish up, pitfalls. Very timely this morning in the publication Stat, there was an interesting article that addressed many important factors. And I would encourage people to seek this article out. I found it particularly interesting and very timely for today's talk. You know, there have been hundreds of studies that really, as we've mentioned, flooded onto preprint servers and into medical journals that have been, you know, claiming to demonstrate AI's ability to perform tasks with high accuracy. And so, you know, last year, a group from Cambridge examined more than 400 models and, you know, determined flaws. The review found that algorithms were often trained on small single origin data samples with limited diversity. They, as again, I know I'm speaking to CSAI ML experts here, but, and this is so much a part of your world. But again, what was shown over and over again in these pre-publication clinical applications of AI was, you know, utilization of the same data for training and testing in the absence of external validation. And ultimately, you know, that this was leading to a credibility crisis, not just amongst CS health experts, but actually, you know, in the clinical world too. Lots of factors. Again, I realize that I'm speaking to the people who know this perhaps the best in the world, but with the intensity to publish, the pressure to publish, the fast pace that this year has taken on with regards to getting preprint publications regarding COVID onto the preprint servers. But again, the biggest concern that was cited in this article, at least, was the lack of external validation and also the lack of large diverse data sets. And that, again, putting emphasis on diversifying these data sets is ultimately going to be beneficial for everyone, including our algorithms and models. Yeah, again, highlighted in this article was there was this article from 2 months ago in Nature Medicine, simply highlighting the lack of prospective studies conducted on AI products that were cleared by the FDA. And I think, again, just challenging us all to continue to look for ways that, you know, as AI is absolutely part of clinical medicine now and will be forever, I think making sure, again, that we have robust external validation opportunities, challenges, but also, you know, as diverse data sets as possible so that we can really adequately and accurately perform those external validations in ways that are both fair and beneficial. So just to finish up, I think machine learning has been integral in accelerating the global vaccine effort against COVID-19. It's certainly very clear to me as an infectious disease physician. MLAI has really touched every aspect of the vaccine response. It's changed the landscape of infectious diseases, I think, forever. And as a clinician, I think the promise that data-driven and pattern-based algorithms and models are bringing to health has never been so apparent and so important. And finally, just regarding the pitfalls, I'll simply add, speaking as a clinician to you all, you know, the problems that were presented in these last 2 or 3 slides are not insurmountable. We know this, but I think gaining trust, continuing to gain trust and acceptance of clinicians is increasingly a big hurdle I see ahead. COVID-19 has presented a huge opportunity, and it's clear that machine learning has established itself as a crucial part of the armamentarium we have for, I would say, really all infectious diseases, and indeed perhaps all diseases going forward. And simply assuring that the external validation, transparency of the data sources remain part of the conversation, I think will help build the faith and trust by clinicians. And increasingly, I think, get us all to lean into your new powerful tools. And with that, William, I will finish up.
Thank you, Ling, for a wonderful presentation. I'm sure we have a lot of questions, so we welcome any questions from the audience. Please type your question in the Q&A module, and then I'll be able to pick up your questions. So I'll just go ahead and start. I think this is definitely a fascinating talk. I have so many questions. I mean, I'm a computer scientist, right? So I have a lot of hopes for AI and machine learning to see them actually helping the next pandemic. Also, I agree totally with you. I think there are also a lot of pitfalls that we should be very careful when applying these technologies to the next pandemic. So one thing I think we didn't get to talk about a lot in our earlier conversation was basically public policy and public health, right? So what do you think about the role of maybe causal inference and maybe some sort of counterfactual reasoning from the AI community? Would that be useful for maybe public policy making? So I'll give you one example. For example, if there's a way that we can build a model to see what if we introduce the face mask mandatories earlier, right? 1 month earlier, what will happen? So what if we actually start the lockdown a month earlier, right? So what will happen to the patients and the infections and all that? So I'm just very curious about your thoughts on maybe the future research along this line.
So I think public policy is a complex topic. Public policy, I mean, I think the CDC, and here in the United States, the CDC experience, I think over the last 18 months has, been, it's been a complex situation, really changing week to week and month to month. I think fundamentally, I believe, I think when you get the clinicians and the public health, I think physicians on board, I think inevitably, I think there's a way forward. I think what is complex about it, and what has been complex about it, without wading into the conversation, is of course politics, is of course competing agendas, and is again at the end of the day the fact that well, it wasn't always the case, but if even two reasonable people, I think, looking at the same data set are going to see are going to see things obviously very differently. And so I think when you use the example of the mask mandate, for me, the question is, who are you trying to persuade? And who is this argument being made to? And I would argue that I think the most important people for the next pandemic to buy in quickly and to, to have that trust are, I think, ultimately the clinician and the public health folks who are the advisors to the politicians and the public policy makers. And I think that the opportunity actually is now. It's not waiting for COVID 20 or 30 or whenever, our next respiratory viral pandemic, because unfortunately there are going to be more. But I think the opportunity is now to build this as part of what we do, what we lean on, and what we trust, so that again, when we need to employ it, when we need to point to it, it's there, and people get behind it.
Thank you, Lynn. The other question I had earlier was also the role of AI in maybe providing care for infectious disease patients. The reason I'm asking is because I remember reading the news very early last year when the pandemic first started that, Seattle hospitals were using, AI robots to actually help providing some basic cares, let's say, getting the medicine or measuring vitals, to reduce the probability of caregivers of getting infected. So what do you think about maybe going to the future when we provide care? How can we use AI to better protect our healthcare workers?
I think it's an inevitability. So I think the question is not if, it's when we're going to be leaning on this. I think that's clearly apparent. I think, though, as you mentioned, I think we need to be cognizant of the pitfalls. And so, at the end of the day, there is something so very inexact about my assessment with me as a person prone to fault who saw a similar thing yesterday and wants to make that bias. And I think the ability to have, again, something that helps me with clinical decision making and support for infectious diseases, I think is inevitably simply a wave, it's the way ahead, essentially. I think that again, so just comparing again, I think that there are certainly physicians, perhaps the generation above me more than my generation, that are less trustful and more wary of the whole thing, as I think, again, many of you probably are well aware. But I think even for my generation, I think what we yearn for is something that we can trust to make us better. And something that we can trust that makes us better has to, again, be so very transparent with the data sources that helped create the model. The example, I read about a couple of days ago was looking at CT scans of the chest with, again, ground glass, and again, an ML approach, an algorithm, a model that seemed to perform very, very well when it was internally validated and then applied to a different population, and it failed so very miserably. And so I think the other challenge is going to be, assuming going forward that clinicians will work in parallel to decision-making support techniques and tools. How is that dance going to evolve in such the way that ultimately we all get better, but that we don't fall victim to some of these pitfalls?
Thank you, Lynn. We have a question from the audience, and the question is, what are your thoughts on the main weaknesses in the strategy for vaccine distribution? What accounts for the discrepancies in vaccination rates across counties with maybe high or low social vulnerability indexes? So what are some possible solutions?
It's an incredibly complex topic. The fact of the matter is, I think that there are so many target areas and opportunities. There are, there are geographic, logistical, and operations, challenges that hopefully are being overcome and addressed. New York City, perhaps close to a vaccine distributor and a massive population center, can easily get vaccine and handle it and the logistics, whereas a small town in Montana, doesn't have that same access and has more operational hurdles. The other part, quite frankly, that I work closely with in our community here in Santa Barbara, California, about 50% of our community ballpark is Hispanic and 50% is non-Hispanic. And there's slightly more granular breakdown, but that's a back of the napkin breakdown. And we've seen huge differences. And some of it has been unfortunately related to access, and we're working very hard to correct that. But the other much more challenging aspect has been, and again, it comes down to, it ultimately still is an opportunity for ML, information access. And what different, this is again wading into more of the social science aspect of clinical medicine, but what data presentations and distributions and sources are most effective to get, let's say a middle-aged Hispanic woman in Santa Barbara, California, the information that she needs to decide whether or not to get the vaccine, compared to a Caucasian 76-year-old white man in the same community. And, and at the end of the day, we do need to tailor our responses. We do need to address, I think, all parts of this. But ultimately, I think with data sets that show us these differences come, I think, potential tech-based, ML-based solutions.
Thank you. Another very interesting question we received from the audience is about local models and generalized models, right? So the question is, are local data sets that lead to local models that work viable option in this case? So I guess the question is, do we want to have a model that works 90% of the time for a local region, or a model that works 80% of the time for a general population?
And I usually give this disclosure at the beginning, but I should give the disclosure. I was a high school physics teacher in a past life. So forgive me for answering the question with a question, but it's a tricky physics teacher technique. But I think the question for me about this very, very good question is, what models are we talking about here? So are we talking about vaccine inequity models? Are we talking about testing, testing allocation, test resource allocations? And I think at the end of the day, as with anything, some combination of both is critically important. But here again is where, as I say, I'm always aware of when I'm wading out of my lane and into perhaps social science, but in this one, I think I'm wading into public policy and politics. At the end of the day, if so much of these distributions, let's say that we're talking about vaccine allocations for the sake of the question, if ultimately these allocations are being determined on a federal level in the United States or on a whole country level in a different country as opposed to in the local health jurisdiction, then I think we have to have both big and small. I think what we have to have, though, and I think we've seen this over and over again, is good, trustworthy, and I think well-informed, but also well-armed health officials on the local level that have also access to more tailored data, and and ideally, with that doesn't necessarily mean having health-based CS experts in every small community in the world, but rather, I think having, what we're doing, what our models, are based on and look like, have them be applicable to, again, very granular, very small level communities. I think there's definitely a lot of power in that too.
Thank you, Ling, so much. I think we still have a lot of questions, but we hope that you can join us in the panel discussion after today's session. So thank you, Ling, again. We really appreciate your presentation and see you soon in the panel discussion.
Thanks, William.
Great. Now we are going to move on to our session for AI and COVID-19. We have 3 speakers in today's session: Laura, Daniel, and Rajesh. They're all here. So we'll just go ahead and start the first talk. So first, let me introduce our first speaker for this session, Laura Vinnet, who is a professor of epidemiology at Maastricht University in Netherlands. She's also affiliated with KU Leuven. She did her PhD from KU Leuven in Belgium, and her work is widely known by many people, specifically one of her recent paper that was published not too long ago on providing a systematic review on COVID-19 prediction models that has received more than 600 citations in little just over a year. So we saw that. I want to turn it over to Laura, who will tell us today about her work on journeying through this orderly world of diagnostic and prognostic models for COVID-19, living systematic review. Laura.
Thank you. I'm hoping you can see my screen. Can you give me? Yes. Okay. Thank you. Yeah. Okay. Thank you for this kind introduction, and thank you for the opportunity to speak to you today about our work. I'm going to pick up or zoom in on a topic that Lynn briefly touched upon, which is AI to support clinical decision making, so in early diagnosis and in clinical management. So a brief outline of what I'm going to do today. We'll start with the what and the why of diagnostic and prognostic models for COVID-19. Then I'll motivate why I did a living review, share with you how we did it, so the methods, what we found, and the results, and then the lessons I'm drawing for the future and our ongoing research. So just to make sure that we're all on the same page here, when I speak of a model, then I mean any data-driven approach that can be used for to support decision-making, clinical decision-making for individual patients. So for example, to make a diagnosis or to give a prognosis by combining several input variables. So that can be images, that can be demographic factors, that can be symptoms, comorbidities, anything like that. So in the clinic, that can be translated into various forms. So often that's a risk score, like we see here, a score calculator. or you can build it into software that automatically interprets a CT scan for you. But you can also translate an equation or an algorithm into a score chart, which can just be used at the bedside, or a decision tree like this. So I mean all of these things when I say a diagnostic or prognostic model. And from the very beginning of this crisis, the healthcare crisis that we're in, there has been a lot of interest in these types of models from academics, from companies, from governments. It was everywhere. And with real impact too. For example, in the UK, the government has sent out recommendation to 1.7 million vulnerable people to stay at home based on their predicted risk, based on an algorithm. So their risk, based on their predicted risk to get severe COVID. And in the United States, several algorithms to predict COVID-19 complications had FDA approval for use in the clinic. And why is that? Well, there's of course a good reason. We know from previous research and other diseases that a good model can actually improve care, so improve patient outcomes, and simultaneously reduce your healthcare costs. An example is risk models for preeclampsia that can inform you when a pregnant patient, how a pregnant patient should be managed. So if you can do this, you can very efficiently allocate your scarce healthcare resources, which for COVID-19 would have been very valuable. Several countries had too few ICU beds, several countries had too few tests, so this could have been very useful. However, there's another side to that coin, and that is that poor prediction models can actually make matters worse. So we know from decision analytic theory that models that yield inaccurate predictions can lead to harmful decisions. And not harmful just compared to a clinician, but even harmful compared to treating all patients as if they will die, or treating all patients as if they have COVID-19. We have also historic examples from previous pandemics. So we know that risk scores that usually work very well to track a person's health during a stay in the intensive care unit did not work well during the 2009 swine flu pandemic. So in this case, this model gave overestimated mortality risks. So if you want to do this, if you want to make this type of model, you should be very careful and aware of the potential benefits and harms. So that was one motivation to do this to start a living review. So first I wanted to just know what's available. Back in spring 2020, there was data in other countries, there was Chinese data, but in the West, we knew nothing. There were so many questions. How are we going to diagnose these patients? Which patients are going to worsen? Which patients should we admit? What should we do? So I wanted to learn from other countries. I wanted to see, is there an algorithm available? And I wanted to give an up-to-date overview. So make sure that we all at any point knew what was available, and also what's available. Not only that, but how good is it? Give a critical appraisal of the models that we have. So that's why we started this effort. We started in March 2020, and in the same month, later that same month, we published our first results, preprint. In April, we had our first journal publication, and then since then, we've had 3 updates published, and the 4th one, we're still working on it. And the reason why we could do this so quickly, why we could start so quickly and get results so quickly from the beginning, well, one of the reasons is that we already had a toolbox available for the systematic review of diagnostic and prognostic models. So one of those tools in my toolbox was a CHARMS checklist. So that's in essence a checklist that gives you all the items that you should extract from a study on a prediction model. Another item in my toolbox is the Probust risk of bias tool. So because we know if you give a number, for example, C statistic or sensitivity or specificity, the numbers are only as good as a process that produced them. So PROBUS asks signaling questions in 4 key domains. For example, the participants or the patients that contributed data, the predictors or the inputs or the features, if you use that terminology, that go into the model, the outcome that you're trying to predict, and the analysis that was done to build the model and to validate it. And in our systematic search, we included peer-reviewed articles from PubMed and Embase, but also preprints. The preprints, we had to drop that starting from the 3rd update because there were just too many. But in the beginning, it was, of course, essential to include them because traditional publishing just wasn't keeping up. And as a side note, once, if we included a peer review, a preprint, and later on it was peer-reviewed and published, we reassessed and re-included that paper into our systematic review. The types of models that we included, we had a very broad search. So you can break it down into 3 types. First are the susceptibility models. So among the people in the general population who are currently healthy, who's at high risk? That's the first type of model. Then the diagnostic models. So from those who present with symptoms or suspected cases, who actually has COVID-19. And then the third type are the prognostic models. So if you've presented with COVID-19, if you've had your diagnosis or it's highly likely that it is COVID-19, what's the course of the disease going to be? Are you, for example, likely to need to be admitted to ICU or will you die, for example? Then each study we found was assessed by 2 researchers working independently and then comparing results. And if there were any conflicts, they were resolved through discussion or through getting a 3rd party involved. And it happened, of course, that more than one model was described in an article. Then we assessed each model separately. So these are the first results. The records we screened, so we screened 37,000 studies, titles, and abstracts. From those, we included 170 studies in our review, and together they presented 236 models. 11 of those models were to identify subjects at risk in the general population. 118 were diagnostic models. 10 of them were models to so among those were models for COVID-19, yes or no, but also 10 that classified COVID-19 according to severity at presentation, and 75 using only images as input. And 107 were prognostic models, for example, for mortality or for progression to a more severe or critical state. A large proportion of the studies we reviewed used single country data. And very often, especially in the beginning, that country was China. But of course, as time progressed, we saw studies from all over the world. The data sets were often rather small. So the average sample size, the median sample size was about 344 patients. And the number of events, which is defined as in a diagnostic model, that would be the number of patients with COVID-19. In a prognostic model, that would be the number of patients who die, for example. That was, the median number was 70. Most models were developed for hospitalized patients, and most models were developed for people with either confirmed or suspected COVID-19. And what's interesting to note is that almost half of the models were readily available for a model in a format to be used in clinical practice. About 1/3 of the models used good old logistic regression. Another third used diverse architectures, neural networks, and deep learning. And then the other third were, well, really various other techniques. None was dominant. If we then go to the included predictors, I should note here, of course, that per model, the definition, the exact definition of the predictor could be different, but the diagnostic models often included vital signs, the flu-like signs and symptoms, age, electrolytes, and image features, whereas the prognostic models, the most commonly used were age, comorbidities, vital signs, image features, and sex. Now, what you all really want to know, of course, is how well did these models do? And here I have very good news for you, because within each type of model, we found models that did almost perfectly. So an area under the curve, or C statistic, that's the same thing for the binary outcomes, of 1, that's perfect. And you see that within each class, we had almost perfect models. So that should really be a cause for mass celebrations, because that means that you can perfectly detect without a PCR test who has COVID-19 and who hasn't, or you could perfectly predict who's likely to die and who will survive. So that would be amazing. But if you dig a little deeper, you will find that most models were either not validated or validated only internally. So only a minority underwent external validation, meaning that they were tested in an independent data set of patients from, for example, another center or another country. And we also found that only 4 models were low risk of bias. 6 models were unclear risk of bias, and 226 had a high risk of bias. So a high risk of bias means that there were flaws in either the design or the analysis of the study that suggests that the estimated predictive performance is too optimistic. And here you see that these problems presented in all types of models and in all robust domains. So what are some common reasons, some common causes for risk of bias? Well, in terms of the participants, there were often inappropriate in or exclusions or inappropriate study designs, which mainly boil down to the fact that the participants that are included are not a good reflection, not a good representation of the real intended clinical target population. The predictors, they were hard to define in imaging studies. So we set them to, in those cases, we set it to unclear, but the overall conclusion, if you would leave out of the analysis that risk of bias domain, was still that the imaging studies were high risk of bias if you only looked at the other domains. Then in terms of outcome, what often happened was that a subjective outcome or a proxy outcome was used. So sometimes a proxy outcome, what sometimes happened was that the researchers used data from before the COVID-19 pandemic. So in their data set, there was not a single COVID-19 patient. They modeled, for example, hospital admissions due to other respiratory illnesses, but then they presented the study and they presented the model as a COVID-19 model, which is of course misleading. Then in terms of the analysis, this was really the biggest issue. And it's an interrelated set of problems that arose in terms of analysis, which is that most of these studies had a very limited sample size, as I showed you earlier. And then the data, the modeling approaches that were used were highly data-driven, leading to overfitting of the algorithm, and then often also optimism in the estimated predicted performance. So the way that predictive performance was calculated was often inappropriate or incomplete. What we often saw was that discrimination was assessed, but calibration was ignored. Calibration, so if my algorithm predicts that somebody has a 20% probability of dying, then I would like that to be 20% in reality. But if you would check calibration for this example, you would see that it was in fact not 20%, it was much closer to 5%. So calibration, assessing the relation between the predicted risk and the observed risk is really something that's not done enough. Luckily, there's good news. There was also, we also found 4 low risk of bias models, which were the Cube COVID models. Those are the models that I showed earlier to be used by the UK government. So these models predict among people who are currently healthy, who's most likely to catch COVID-19 and subsequently either die with it or be hospitalized with it. So they use data from 910 general practices across the UK, over 6 million patients. And later on, they validated externally in 80% of English adults. That's amazing, that's mind-blowing. So data from 80% of English adults, and they performed excellent. There was no overfitting, it was as in the development sample. So with only one high risk of bias model, you can ask yourself the question, well, only one low risk of bias model, you can ask yourself the question, were they too critical? Were they too harsh? Unfortunately, external validation studies have confirmed our fears that these estimates of performance were too optimistic. And this plot is from one such study. So the colored curves falling below the horizontal line show that when these models are tested, they are less useful than oxygen saturation alone or than age alone to predict deterioration or mortality, which is really a cause for concern if you realize that these models often use age or oxygen saturation as one of their predictors. So they actually made it worse. So earlier on in the session, there was a question on should you want a model that is externally valid, that keeps its performance if you transport it to another setting? Is it not enough to have local performance? Well, if I see something like this, I don't believe that the model was working locally in the first place. I think it may have picked up some spurious correlations, or that there was some leakage of the labels, that the model was somehow aware, picked up something else. And this wasn't the only study showing something like this, so there were many other validation studies that found similar results. So the impact of this research was that the World Health Organization picked up our review, and they recommended that such models for prognosis would not be used in the clinic. Like any study, ours also has limitations. One of my frustrations is that I know that there are other models available, often in-house developed models or proprietary algorithms that are not accompanied by a scientific report. And because there was no scientific paper, they fall outside the scope of the review. I could elaborate on this, but I won't. I will just say that there are some indications that their quality is not better than what we have seen. So in terms of lessons for the future, I realized that this is a disappointing image that I'm painting of this field. So I want to reflect on, I was disappointed as well. So we have to ask ourselves, how can we do better next time? And I think one issue is that we have to share representative data. So there has been some sharing of data, even though it's really hard to convince people or hospitals or researchers to share their patient data. to collaborate on this topic. There has been some, but in case the data was shared, it was often very poorly documented. So you didn't really know what type of patients were in the database. And I think we really need to work in multidisciplinary teams. So I've seen both sides. I've seen highly technical papers, but there wasn't really a clinical use to the models that they were proposing. And I've seen models that were made by clinicians with a clear clinical use, but they were built in a very amateuristic way. So you want to collaborate, you want to combine the strengths of both worlds. And then I'd like to make a case for sharing models so that other people quickly can test whether the models work on their data, so that you can quickly do head-to-head comparisons of different models and identify those that work best in a wide array of settings. In terms of doing a study yourself, I also think, well, make sure that you report everything clearly, because we also had a lot of unclear risk of bias models just because it wasn't documented what was done. In terms of ongoing work, we're working on the 4th update. We've identified over 350 models, and that's after excluding the AI on medical images. So there's really a tsunami of diagnostic and prognostic models out there. And this is more than double what we've done in the previous versions combined. So really a lot of studies still appearing. We're also doing an IPD meta-analysis for validation, which means that we combine the original study data from the original studies. We've contacted the researchers, and we're using each data set to test the best models or some of the models that have been proposed. We're also working on a more detailed comparison of the quality of the preprint and the published versions of studies that we've reviewed. And there's been a paucity of models developed for primary care, whereas patients presenting in primary care, it's really hard for a general practitioner to predict whether that patient will deteriorate. So we're working on that using primary care data from the Netherlands. So in conclusion, despite reports of impressive predictive performance, much of this fast-growing body of literature on prediction in COVID-19 was of low quality. So I would recommend that you never trust good reported performance alone. Check the study's design, check the analysis that was done, and check the way in which the model was validated. So this was a big effort. So I have a very big team to be very thankful to. And if you want to know more, we have a website where we have details on all of the models that we have reviewed. We also have a layman's summary written by COVID-19 survivors. And any questions that you may have, I'm happy to answer them. If not today, then maybe via email or Twitter. So thanks very much for your attention.
Thank you, Laura, for a wonderful presentation. Again, I have many questions. I think I'll just start with one, but we can maybe have the rest of them discussed in the panel afterwards. So one question I have is that I think you had a very good point about dataset bias. And when you talk about neural networks and other machine learning models, I think they're very good at exploiting this spurious statistical patterns between your input and your output. So for example, maybe we want to look at, CT scans for predicting pneumonia, but then we ended up actually using machine learning to learn the type of CT machines, right? So that happens very often rather than catching the true predictor. So how do you think we can deal with this kind of issue?
Yeah, I think external validation would be very useful here. Why can we not test them on data from other machines to pick it up? It's what we do in statistical modeling, traditional statistical or machine learning models. So why can we not do it there? I realize you need to do some retraining. It should be able to pick it up, right?
Right. Yeah, I think the issue is that when you see this 99% accuracy or 95% accuracy it's a little bit unclear, right? Whether you're really getting the 95 accuracy or whether you're just picking up, you know, some of the unwanted property. But I certainly agree. I think maybe actual validation on additional data set. I think that's when people found out there were these issues.
Yeah, and yeah, maybe making it explainable, of course. See what it is actually picking up. Documenting also very well all this metadata. So what type of machines were used, how were the images manipulated, what kind of pre-processing was done, how were the images cropped. Yeah, we know how to do it. It's just not being done.
I totally agree. So again, I think I have a couple of questions along this line. We can continue the discussion in the panel discussion in about 40 minutes. So thank you again, Laura. We'll see you soon in the panel.
Thanks.
Great. Now we can proceed to the second talk in today's session. For the second talk in today's presentation, we have Daniel Cho from UC Irvine. And Daniel is an assistant professor in residence at UC Irvine in the Department of Radiology Sciences with joint appointments in neurology and experimental pathology. At UC Irvine, Daniel co-founded and currently he co-directs the Center for Artificial Intelligence in Diagnostic Medicine, and he's also leading efforts in precision health through the Artificial Intelligence Academic Initiative. So welcome, Daniel.
Thank you very much for having me. So, you know, I want to emphasize that what I'm going to be sharing is, you know, our single-center experiments about how we deployed and developed an AI and advanced analytics tool to assess COVID risk. I do want to start with one disclosure, and that is, you know, I am a clinician. I am not a software developer. I co-direct the center with Peter Chang, and he is really the technical brain of this. But I'm here to share kind of like my clinical lens on this experience. So, you know, I think we've seen similar slides already that, you know, we saw early on from the literature in Asia and Europe about some patients who were very, very refractory to different types of therapies. These are parents that who would require ICU care early on, ventilator support, and ultimately failed therapies. However, there was a large challenge in interpreting these results is that there was, at one point, we had identified over 70 clinical, laboratory, and imaging parameters that may or may not be useful in separating these COVID-19 patients. And at a time during a pandemic, you know, it's difficult, if not impossible, for a clinician to digest, integrate, and process this swath of information in real time. The other challenge that we observed very quickly was that our populations were very, very different. At UCI, we noticed that our patients were typically younger than those in Europe, but also they were also sicker and they had different numbers of comorbidities. The other thing was also that they had different comorbidities. So this was a really nice calculator from a Chinese group, and this was published in, I think, JAMA. And you know, they had a really, really good performance when used in their own population. However, when us and another partner at the University of UC and Emory, we tried to use the calculator, we observed that the AUC dropped from the reported 0.9 to almost 0.6. And then we started teasing this apart. And some of the things that became very clear were, you know, when you look at the different types of comorbidities, for example, you know, one of the early iterations, they had anorexia as a comorbidity, whereas for us, we're dealing with obesity. You know, they have a lot of panels dealing directly with hepatic function, hepatitis B, and so forth. And we didn't observe that to be a significant predictor in our population. And so we realized that, you know, we needed to make a local solution that made sense for us. So, you know, our goals was, you know, to really develop a model, validate it, and then to really quickly deploy this and see, could we use this to identify patients who are at high risk to help with triage. And, you know, I completely agree with the prior speaker is that this really needs to be driven by engagement and a multidisciplinary focus. I think too often as data scientists, there is this tendency to want to take a look at all of the data, and then once you have the data to try to make some insights and develop a solution. But really, in our experience, what we have found is by engaging clinicians early on and understanding what are your needs and your challenges, then we know how to look at the data a little bit better, and I'll talk about that in a second. And so really, this was our team. So we knew that, we wanted to deploy this into the hospital. We had folks involved from computer sciences, also regulatory and public health, along with the hospital administrations for how would this tool look like and how would this fit in for patient workflow. I'm not going to go into too much of the technical details. So this is a slide that we had done by April. So we had our first patient on, I think, March 16th, March 18th. And so we were trying to quickly accumulate data. And so we had done an initial literature review. We had looked at what were the bigger laboratory predictors, including LDH, procalcitonin, CRP, and we had determined what are the comorbidities that we were examining for them. At the same time, we were meeting with our ICU physicians and medicine almost on an every other day basis to try to glean from their experience. And we would tune this model on a regular basis. What's interesting is that we had actually initially tried something fun. We tried to see, can we do something sophisticated with either deep learning or SVM or random forest? But what turned out to be the best predictor was just a variant of a logistic regression. So on the internal validation, this wasn't too surprising to us. This did really well, and we had giant concerns of overfitting. And so we had one of our partners from Emory give us a match balance data set. And this was still performing in a realm that we were comfortable with when we had externally validated our model with Emory's patients. Our inputs it was a very binary input. It was those who went to the ICU and required mechanical ventilation versus those who did not. So it was a 0-1 output. And so this was the final product of the tool. And this is something that we had to reiterate over the 6 months. And I'll talk about that in a later slide. So the clinical inputs, we had some clinical inputs for age, gender, the types of comorbidities, as well as something that we termed our COVID severity screening labs. And so this is from the experience that we gained from our clinicians and the literature review that we just started obtaining these labs in every single COVID patient that we had. We know that we had relatively good acceptance from our team, so we were monitoring the notes on an almost daily basis. And so these are examples. So for us, a cutoff of 30% meant going high risk for going to the ICU. And so, for example, we had a 49-year-old patient who had in their clinical note, and these are excerpts from EPIC. And these are all patients who would subsequently go to the ICU within a couple of days. So I want to share the timeline for how we did things and kind of share this single center experience. So that slide that I talked about in engaging the stakeholders, we had started that process back in January from watching the reports. We knew that it wasn't a matter of if this would come to the US, this is a matter of when, and how would we deal with this. I actually remember one of our initial grant submissions, there was this question on, will we have enough data to build this model? And our response was, we're really hoping that we don't, but if we do, then this is something that we have to have in place. The nice thing is, so by March, because this was a very, very new experience, and because of this really frequent data engagement loop, we were tracking all the labs that were ordered for all of our COVID patients. And what we noticed was this experience where you'd have, this is a patient where on this day, this ER doctor ordered something, this inpatient doctor ordered something else. And as the shifts go on, different clinicians are reading different articles and they're ordering different labs. And so we were able to work with the hospital to just standardize a COVID severity screening lab panel. And so we can see that after that intervention, everyone always got the same types of labs orders, which was really, really nice. And then this is where kind of that engagement data loop helped, because we were engaging early. We were able to very early on have an intervention that improves the quality of the data, which is good for future model building, but it's also good for patient care. The other things that we were doing is that as we were working with public health, we were starting to see disparities within different populations and different geographic regions that we were involved in. At one point, our lab was involved in contact tracing, where it'd be kind of ominous, where you'd see 5 people from the same apartment block all get COVID, and then we would call public health and let them know about that. And then, with that, we were able to kind of raise awareness and identify what were the geographic and ethnic hotspots for where COVID was hitting hardest. This was also important for education of the community. And one of the things that we definitely saw was that while Orange County is a diverse area, it was definitely more North OC, where you have the lower social economic and the higher Hispanic Latinx population kind of the hardest hit, as opposed to South OC. And so by June, we had deployed our tool, which was right in time for our first surge. And so those clinical notes that you saw was around those June time notes. And then by December, I think everyone in California knows this is when we were fully engaged. And between June and December, we were actively fine-tuning the model. And what we observed is, as time went on closer to December, the AUC of our model dropped from 0.9 to 0.8. And when we were kind of anticipating this, because what had happened was our criteria for entering the ICU became much more strict. And so that's why we had to rebalance the thresholds, which is interesting. Since then, moving forward, we have been working with the federal COVID response to see, can we do a better job in identifying not just a binary outcome, but overall severity, and also can we help with patient selection. So this was an unintended byproduct of the calculator. So even though the VSS, which we call the vulnerability scoring scale, was used for just yes, no for ICU versus non-ICU, what we observed was that the scores themselves began to track pretty well for overall disease severity. We can see that the average score of those who would pass upon admission was significantly higher than the remaining group. And by the time that patients were leaving, they were hitting around the 10 percentile. And so we began using this for hospital at home and kind of as a cutoff for determining when safe enough to go, or maybe keep them in house for another day. And so one of the things that we've been moving more towards now is, can we do better for, say, targeting therapy? So this was an example from early on for some of the monoclonal antibodies where they had a risk factor-based selection. If you look at the initial emergency use authorization, some of the things that they had to look at for what is a high-risk patient was age 65 automatically got you in, age 55 with a certain comorbidity. But what we found with the calculator was we were able to identify additional patients who could benefit from therapy. And these were the cases that kind of actually made sense. For example, 65 was a hard cutoff, but there's no reason why a 64-year-old, who's at the cusp shouldn't get therapy also. And so we ended up using a combination of the EUA and our vulnerability scoring system. It's really hard to tell a patient that, if you come back, if you were born 1 month later, you could have gotten therapy. And so that's kind of, when we working with the clinicians together, we were able to put this all together. So I think I wanted to leave with one article I saw recently in Politico, and it was a little bit of a pessimistic article, and it kind of observed that AI has really demonstrated its own limits during the COVID response. But I think one thing I would argue is that the COVID pandemic has also demonstrated the potential of AI, and really, we need to do a better job with working with clinicians, engaging them early, and identifying what are the solutions that you need, and how can we work together to benefit our patients. A lot of the things that we made were, came about from this relationship. We started out wanting to make a COVID risk tool, but in the process, we were able to standardize all the labs for all of our patients, identify high-risk populations, and then ultimately work for this goal. So I think, it's really, medicine and science is no longer a silo. It really is a large team effort. So that's my slides, and thank you.
Thank you, Daniel, for a wonderful presentation. I have a few questions, so I'll ask them now, and then maybe we can continue discussion in the panel later. So one thing I think I'm very curious is when you are evaluating the performance of this risk assessment machine learning models, how do you measure the agreement between human, right, doctors, and also machine, right, for this kind of evaluation? What are the errors possibly come from this machine prediction? So if you do error analysis, what are these different type of errors in predicting risk from machine, and how is that different from human? So human may also make mistakes, but do you compare the similarities and differences in the assessment?
Yeah, so I think this, so one of the things that we had to really struggle early on was because initially the outcome was just going to the ICU. And going to the ICU is kind of what the clinician thinks, that they're sick enough to go to the ICU. Eventually, what we had to change the outcome to was requiring supplemental oxygen, either through high flow or through mechanical ventilation. So we had to change those. And what we found was that honestly, the clinicians generally did a pretty good job of identifying those high-risk patients. I think especially as the disease carried on. I think early on in June, the model was performing almost as good, but by December, we had gotten so much experience seeing these patients that clinicians became very, very, very good at identifying these patients. So much so that the calculator was just used more as a crutch. And I had talked to some of our pulmonary critical care doctors, and they said that, and this is an entirely different discussion, but they were talking about the human-machine interaction. Between June and August, they had used our calculator a lot. And by the time December had hit, whenever they ordered a COVID severity panel, in their own brains, they could kind of figure out what the risk score would be. And so it's almost as if they didn't need to calculate anymore. So we were kind of proud of that. And so they were actually saying that it helped them identify those high-risk patients. In terms of the error, the biggest challenge that we had was the outputs was a moving target, because eventually, early on, if you look at some of the East Coast data, we were intubating early, and by the end of it, we were intubating later. And so our outputs were kind of changing also. So that was kind of another interesting challenge.
I see. Thank you. The second question I have along this line is that, in general, from your experience, how many samples do you think are enough, right,
Yeah.
for machine learning to do this risk assessment? So maybe you can share some experience.
That is a great question. So we were training up until about patient. So by the time we had gotten to about 250 or 300 patients, our AUC had kind of plateaued, and we were still doing subsequent retraining almost on an every other week basis. And we found that it kind of had just plateaued and it wasn't really improving afterwards. We're at about, I want to say about 2,500 to 3,000 patients now when we include some of the ER patients. And what we're finding is that we're going to start trying to explore the more sophisticated models, but some of the laboratory features associated with severe COVID, for example, CRP and LDH, there's such strong weights that we never really found a way to leave linear regression, honestly. And so we plateaued pretty early. Now, I will say though, as the model improved, every single time we would try to revalidate with Emory, that's where we saw the bigger improvements. And so that's kind of my thought, that I'm not sure. I agree that we need comprehensive data sets, but it needs to be comprehensive for what you're trying to answer in the question. I agree with the other speaker. So for example, we wanted a tool that would work for Orange County and work for our patient population. And so in that sense, it made sense for us to keep retraining our own data.
Thank you.
Sorry, go ahead.
Yeah, so I mean, I was just about to say Link's question in our chat. So I had pretty much the same question, because I was also very curious about the data distribution shift and what about the variance. And I think that pretty much connected to Link's question here, that she's asking about, how many samples do you, use to reset the model, and because things are changed so quickly, and how can we have have this built-in iterations that are founded on more recent cases?
I actually think that we should have built-in iterations on more recent cases, and the reason why is like I said earlier, the outputs were changing. Our criteria for getting into the ICU and getting ventilated was also changing, and so we had to continually make those refinements. The balance, though, was that I remember this conversation with our chair of medicine, who's saying that if we keep making these micro adjustments, it's going to confuse clinicians. And so what we had done was we had set the initial 30% at the risk profile. And so we would always jerry-rig the calculations so that that 30% was a threshold as to not confuse the clinicians. But at a certain point, we just said that the AUC is no longer improving, and then we had to divert resources to other projects. But I do think that it's important to realize that as the disease changes, then you have to have the model change with it.
Thank you, Daniel. And I think we're right on time. And thank you again, Daniel, for a wonderful presentation. We're looking forward to continue our discussion in a panel. Now we will move on to the third speaker for our presentation today. And the third speaker is Rajesh Raghunath from NYU's Computer Science Department. Rajesh is an assistant professor in both the Korean Institute of Mathematical Sciences and also the Center for Data Science. He is an affiliate faculty member in the Department of Population Health at NYU Medical Center. His main research is on inference algorithms, causal inference, probabilistic models, and machine learning for healthcare. So welcome, Rajesh, and we're looking forward to your presentation.
Thank you all for having me. The story that I'm going to tell is going to share some similarities with the previous one and raise some issues that the speaker before that raised. But before I go in, I'd like to talk a little bit about AI for healthcare. And there have been some successes. For example, there have been successes in diagnosing diabetic retinopathy from images of the retina. There have also been some use cases on classification of like pathology images. These are prostate slides. There have been some successes and problems on for classifiers of chest radiographs. There are a ton of predictive models for septic shock. And in general, like AI is starting to appear in these places. But like all problems in medicine where AI can be used, they're not the same. And it kind of matters like where you are on like a spectrum of problems. And the challenges really come in through the data and the issues with the data that can be involved. On one end of the spectrum, we have perceptual problems. And on the other hand, we have causal problems. And as we move from one end to the other, there's going to be more noise and you're going to need more assumptions to be able to do something that you hope would generalize. For example, for perception problems, I like to draw these plots here where you have different kinds of measurements, measurement A, B, and C. Time is increasing to the right. And perceptual problems are one where the answer is actually in the data that you collect. So you have a measurement, and in this measurement, there is something that you want to label. It could be something like cardiomegaly. It could be the kind of cells that you would see in like a prostate pathology slide, or it could be some kind of cardiac arrhythmia. And it's kind of the nicest case, mostly because like, you collect your data, the answer is in the data. You don't have to worry about like problems about like missingness and labeling. There can be selection bias though in your sample. If you go a little bit further, there's like a fun class of problems, which I call estimation problems, where here there's not much of an aspect of time, but you're collecting one kind of measurement, say measurement C, and you want to make a prediction about generally a harder to collect or more expensive to collect measurement in measurement B. An example of this, which is kind of a pictorial example, is predicting somebody's BMI from their retinal scan. A more practical example would be predicting ejection fraction from an electrocardiogram. Kind of the problem that we always think in our minds of when we think about like AI and healthcare is one about prediction, where you have something that you observe about a patient right now. You get to see some function of their current measurements, or you get to see all of their measurements, and you want to make a prediction into the future. Here, things get a little bit harder because not only can you have like missing labels, you can have missing data at the start. You can have things that are happening across time that need to be accounted for. You can have censoring. There are many more problems that can occur than sort of like the standard. And kind of what you see is like, as I'm going to go on in this spectrum, there are going to be fewer and fewer things that I'll cite. And for the final one, for causation, I'm not going to cite anything because, not only do you have all the issues that you have in predictive models, there's confounding that's at play here too. And so the picture, rather than taking it from a paper, is one that I hand drew. And it's mostly because like, as we go like further and further and further along the spectrum, the data becomes more difficult. And like anytime you have missing data, anytime you have censoring, anytime you have confounders, you're going to need to make assumptions. And the more assumptions you make, the more you have to think about your data, and the harder it is to understand whether those assumptions will hold to generalize. And like fundamentally what it boils down to is that a lot of data in healthcare is difficult. People visit the doctor irregularly. People, they get censored. They might move to a different location. There's confounding everywhere. Populations look really different in different ways. Like if you look at the West Coast population versus say the Italian population, they look very different. And like dealing with these challenges are sort of the main bottleneck in sort of making AI more broadly useful in medicine. And a lot of what my lab works on are basically methodologies for addressing issues that occur. Issues for like missing data and censoring, for causal inference, hypothesis testing and explainability to uncover when some of these issues are happening, and probabilistic modeling to account for uncertainties. But, with COVID-19, there's an opportunity to actually see if any of these techniques or some of these techniques that, the community has been putting together actually would have some value for like a real problem where people really didn't know much. And this is joint work with like a giant team. And my part, I'm a computer scientist, and my part and my students' part are really focused on like model building and model checking. There's, model deployment. There are a bunch of clinicians who are involved to provide information about like what needs to go in and what the question is. It takes a giant team to get this done. But, to start off, there've been a ton of COVID deaths in the United States. This chart is a little bit out of date. I think we're almost at 600,000 now. And, the question that we're really wondering is like, how do you make AI models that help with COVID-19? But there are a couple of things that you need to have, first before you even try to like run any code or do anything. One is like the data should be available. And it's important that the data is available for the question that is of interest. Second, you also want to pick questions where like, if you knew the answer to whatever question that you built your model for, and you can assume that it's predicting perfectly, then if you had knowledge of that, you could do something about it. There are certain questions where the ability to do something might be quite limited because it's just not known what to be done. And finally, you also need to talk to people who are on the clinical team. Like from the computer science side, somebody could hand me a data set and I could build something. I could even build something where like knowledge of the prediction would help. But if there's not support, or and there's not like a desire to use these methods, or like to use whatever gets produced at the end, then they won't get used. And so you kind of need clinical leaders who run like various services in the hospital to be on board with what you're doing. And so at the very first, I got approached by people at the hospital about predicting people who are have COVID from just lab values that are easy to collect. Because in New York, at the start of the pandemic last March, here, the testing was really unavailable. Like you had to wait a couple of days to know whether someone had COVID or not. And so there was a question of like, can you predict this beforehand? And the problem with this is that like, well, by the time the data comes to be available to predict this, then testing became more available. And so this use case really disappears. Next, we're like, can you predict adverse events? And then from discussion, basically we came to the conclusion that like everything was really at capacity in New York at that time. And so when you predict somebody is going to have an adverse event in the future, there's not really anything that you can take as an action, because every like ICU bed or every other place where you might send them is already full, and you're dealing with people who are having the adverse event right now, rather than like trying to like prevent people or do something for people who would be having it in the future. And if you swap that problem though, like if you just like flip the label on that, somehow it becomes far more palatable, where instead of saying that you want to predict adverse events, you want to predict no adverse event in a certain time period. And this can be helpful because like rather than imagining this world where you have somebody who needs more care, you can imagine it as like somebody who's receiving more care, can they get less care? Because that could free up a spot. But it's just the swapping of the label. And the data we took was from March and April of last year. And it's about 3,000 plus patients admitted across all of the NYU Langone campuses. And the adverse events that we looked at were in a 96-hour window at the time of prediction. And they included things like ICU transfer, death, ED representation, hospice discharge, and needing significant oxygen. And the inputs provided were from a 12-hour window. And for things that are sampled more rarely, it's the most recent value. And so there are a bunch of features that were easy to collect that clinicians provided input on based on existing literature that they're like, we should include lots of most recent lab values, vital signs, O2, also demographics and days since admission. And they're like, you can build a model. And so, people built a machine learning model on this gradient boosting. It's a tree-based ensemble model. It's maybe the easiest way to think about it. And it works well. I don't have any numbers on here because the numbers aren't necessarily so important. Here, if we look and see like what is a good curve here, so this is what the boosting is. A good curve would be up and to the left, and this is pretty far up and to the left. And on the precision recall curve, a good curve would be like, flat at the top, and this is like, pretty close to the top. And so you might think it's good, but like, it's like very hard for me to tell at this point, is it a good model? Like, this was built and handed and like, it's very hard for me to tell. And let me say why. And like, for me, as somebody who's a computer scientist, the reason it's very hard for me to tell is that the distribution of people and like what's happening to them and like basically everything is changing a lot. And here I picked out one example from the time period from which our data was collected, where like if we look and see there's something called hydroxychloroquine. Hydroxychloroquine and chloroquine were FDA authorized for emergency use in March of 2020. By May of 2020, there's a large observational study that finds no relationship. And in June of 2020, the FDA writes a letter to withdraw emergency use authorization, and the corresponding trial associated with it was stopped. And this change in data is like a big thing. Like hydroxychloroquine has side effects and can also be a cause of death through like QT prolongation. And it's very, very difficult. Like, if I remember like my class or even the classes I teach now, and I'm like, the assumption that you want is that things are like independent and identically distributed. And I was like, this is not happening. And so you have to be very, very careful if you're going to use or report this in any way. And so we need to check the data. And this is really a question, not necessarily about models, but it's like, how good is the data? Are there data issues? Are there data issues we're not aware of? And the data is really messy. And this is like an image of my graduate student, Mukund Sudarshan, who did the most of the work of this part on this project. And like, he has this tears coming down, mostly because there's just like 65 values, and to carefully check each one takes a large amount of time. And so we're like, how can we simplify this? And this is where like statistics and machine learning helped a little bit. So we decided to use something called a conditional randomization test. It's a hypothesis test where the null hypothesis is that a feature, like your jth input, is independent of the label given the rest of the features. So it means it provides no information to predict given that you know everything else. And the way that you would run this test is you try to simulate synthetic features for a particular dimension, we'll call it dimension J, using the rest of the features. And these synthetic features by construction look like the original features, but they have no relationship with the label if we have knowledge of the rest of the features. And then once you have these like synthetic data sets that have no extra information, as I call it, then you can compute a test statistic on those simulations and compare them to the real data. If the real data has a lot of information, then it should stand out relative to the sampled like spurious looking information that will occur just because we only have a finite amount of data. Two questions. One is like, how do you actually produce these samples from the null and what makes a good test statistic? And this is where machine learning can really help. You can train deep probabilistic regressions to produce simulations from the null, and you can learn them all at once using something called a deep generative model. For test statistics, AI models are really good at picking up at anything, even if, as you know, the previous speakers have noted, they can pick up on things that are spurious. But that helps in like building a good, that helps in trying to see if there's any relationship, even if that relationship is unintended because of problems in the data. And you can better control like your error rates. In this case, it's a false discovery rate by mixing in contrarian models to account for errors in estimation. But once we do this, you know, we can take a conditional randomization test, power it with like neural networks, and we can reduce the number of inputs from 65 to 16. And really the motivation behind this first step was, you know, I'm like really wary of like building a model and then not looking at it and knowing for a fact that the data distribution is changing and not going in. And so this reduction was really like to make things easier to audit. And so then we did go in and we audited things. And so this is a histogram of the BMI for the patients in our training data. We can see from this that there's something very, very odd here. There are a lot of patients that have BMI 0. So as far as a computer is concerned, BMI 0 is like a perfectly normal thing. There has no prior information or no knowledge by which to assess that BMI 0 is like something that you should be really concerned about. And like, you know, people don't have 0 BMI. And it was kind of a curiosity. Like we didn't know enough. And it took quite a bit of time to understand exactly what was happening. Like, you know, like my initial guess was maybe that like people who are very sick are not getting their BMI taken. And then doctors were like, no, they have bed scales. These bed scales are recording their weight, and that's used to be computing their BMI. But it turns out that like it's like a data provenance issue about like how that data gets moved into the database and the time at which it becomes available. And it's like once I start hearing stuff like that, I'm like, it's less likely to generalize, because like if your predictive model relies on things that are process issues, and process issues can change, like if somebody changes like this data processing pipeline, it can be like, you know, it's hard to believe that, you know, your model will be stable to like these things that shouldn't matter for what's going on. And it's hard to understand that this is even happening. Like if you just trained that gradient boosted machine and you evaluated it on held out data, you wouldn't even realize that something like this could be happening. Like you really have to go in and get your hands dirty. But like with fewer inputs, it's less consuming to check plots like this. You know, there are various other kinds of plots that were looked at. And in this case, you know, BMI was going to be omitted because this like missingness is very particular, and using information provided by that mechanism is not likely to be stable across even time at a single site. But then like, you know, once you've like audited the data and you've built a predictive model, you actually need to deploy and convey the model. And there are a couple of criteria that you want to have. First is you need something that's like simple enough to understand. And this understanding is not necessarily because like it's very, very important that people can, you know, process what a computer can do. It's more because like the faith in the data may be like far less than what you'd hope it would be. You also need it to be easy to deploy. There are lots of limitations in like the kinds of models that can be deployed inside systems. For example, like we originally wanted to deploy the model in a way that would make it accessible to a broad collection of a particular EHR vendor's users. But it was a bit challenging given the constraints that were placed. And so we had to like move to a different subset. And we'd also want it to be easy to visualize, because like part of the value, as the previous speaker mentioned, will turn out to be not in necessarily listening to the predictive model and using it to make the decisions, but in like understanding like what's important, and like doctors can figure out like, hey, these are the things that are important and can make use of it over time. And here, like if you can build an accurate linear model with few inputs, we'd have something that would meet our criteria. And accurate is important because like if you think about like two models and one performs a lot better, you'd be hesitant to use the one that performs worse if you are only doing it for visualization. And so we don't have too many inputs, and you can use a nonlinear model to try to look for, try to uncover the places where things are nonlinear. And so one way to do that is if you have logistic regression and you take the log odds, it's going to be linear in the log odds. And so you can like take the nonlinear model and then try to plot what the log odds are, where you remove the other features effectively by integrating them out. And you'd expect to see a line if it actually would match the assumptions that logistic regression has. And for most features, you actually do see a line. And these features are like quite nice. But for one, which is like the maximum O2 rate, it's not. There's kind of like different like regions of it. And there are also some kinds of outliers that are like important to handle, because if you have like a tree-based model, you can like segment out outliers, but a linear model is going to be like whether they're outliers in the labels, if you are doing like real valued responses, or outliers in the covariates, they can influence a lot of what happens. And so here we just did something very simple. We're like, there are a couple of regimes here. Let's just break that up into 3 separate features, or 2, because the last one can get encoded by the bias. And let's try to build a model. And so, through this process, we took this model that was originally like quite large in the sense of like having large numbers of inputs. The inputs weren't validated in any way, and also was like nonlinear. And we replaced it with a linear model with only 14 variables, and performance is very, very similar. Again, I don't put numbers here, and we'll see why in just a second. But performance is, like very, very close to this other model that we started with that was the same. But one that didn't make use of all of the inputs. And it's this was deployed, and it's relatively easy to visualize. Here is a case of somebody who is like having like overall high risk, and this one is a person who has low risk, and you can see like the factors contributing to what's going on. And this model was also prospectively validated in that we had 445 patients that were collected after the model was completely finished. And then we asked like, how well does it do? And it does quite well, both in terms of like average precision and under the ROC curve. And if we go even further for a longer perspective evaluation, it holds up well as well. But like deployment is not really magic. There are many, many, many decisions left. For example, monitoring is a really important one, because adverse events went down over time in our population, meaning that like, either from like the lack of treating with medications that have side effects but very little value, or from learning how to treat patients better, the overall rate of adverse events went down. There's also a cost of using a linear model. It can lead to oddities like hypothermia being protective. You can imagine like if a high fever is going to make your risk of having an adverse event higher, then like if you have a linear model, you might get a positive coefficient where if you start driving that temperature down lower and lower and lower, you would be like, well, the risk is going to be lower. In silent deployment, we found that like the correct labels at a 90% positive predictive value threshold were an average of 1 day earlier. And most from like talking to clinicians and interviewing them for feedback, the hospital found like most of the utility in this model is not in terms of like, being like, hey, computer, make the decision for what I should do. Rather, it was in just like learning to understand, or like understanding what factors they should be keeping track of for their COVID-19 patients. There was a lot of varying information early on in the pandemic, and they were like, oh, this is what I see. It's holding up. And they found it very helpful into figuring out like, what are just the things to pay attention to. But in terms of like really like, sending it home, I would say that, we're not done. We need research in effectiveness. And there are a couple of challenges, especially doing this at a single site for research in effectiveness. First, people can influence each other based on the model. So for example, if you were trying to say run like a randomized trial at a single site, one doctor could have lunch with their friend who's another doctor who hasn't seen the model and be like, hey, these factors I found are very helpful in treating my patients. And so they're indirect effects, kind of like with vaccination, where if you give somebody a vaccine, then the people they are around will be protected because they're not going to transmit as much. People also can learn to mimic the model, and we found that's a positive thing, but over time that like you don't actually need to pay attention to it. And those first two things, I think Ziad on the first day I was able to catch his talk mentioned doing a cluster randomized trial, and like those kinds of designs can help with those. But like for the third and fourth point here, it's a little bit harder. Like people can also ignore the model. Like if you tell a doctor like use this model in making a decision, it's kind of vague, and it's not like taking a pill where it's like, you know, the pill was taken or it's not. And so like when you have a model, there also has to be some kind of protocol for like the use of the model that's very tight. And the problem with that protocol often is that it's hard to balance the model's utility with like the value that like the clinician has. Like you can imagine a protocol where the clinician is forced to listen to the model, but so it's somehow like not the right protocol for most of the cases where AI has a chance to be useful now. And also people can misinterpret the model. Like you always have to think about like what these interpretations are. For us, you know, like for people who are like doing the data side, like interpretations and explanations are super helpful because they help identify what's going on. But the utility of these like interpretations and explanations at the bedside is a little bit more questionable, because you have to have some faith in that like this like very broad set of people who aren't trained in like using or seeing what these things will like interpret in the right way. All the evaluations I also presented were discriminative, and discriminative is important, but kind of like in survival analysis where concordance as an evaluation looks at like how correct are the orderings of patients' predicted survival times. It's not necessarily obvious that you want like a comparative evaluation unless there's a resource constraint. So there for like survival analysis, you might want that kind of evaluation if you have like a resource constraint, like a liver, like for a liver transplant. But if you can treat each patient individually, then there might be other individualized evaluations that you want. And a lot of this process that I talked about, like some of it was automated, you know, like when we did those randomization tests with neural networks, that part was automated. But then when we moved like one step downstream, when we moved into using like these plots of the data to try to figure out what's going on inside of them, then there was a lot of knowledge and a lot of like talking to a large number of people that like my students and the rest of the team did to figure out like, hey, why is BMI 0 for 1,000 patients? But a lot of the issues I talked about also translate to less time sensitive models. So there was like a real time pressure, like, you know, it's like really need to get this out as quick as possible because people don't really know what's going on. But like a lot of the issues about like, you know, just reporting like a performance and being happy with it is like maybe a bit dubious, because it's really hard to appreciate like what is the quality of the data that's going in and what are like the oddities that might make a model have good discriminative performance. Thanks, everyone.
Thank you, Rajesh, for a wonderful presentation. I have maybe two questions, and then we can move to the panel. So one question for you is that I think you mentioned there are a lot of challenges when you are predicting from multiple time series and trying to aggregate information. So I'm very curious about your thoughts. You know, let's say when you have this predicted problems, but you have multiple time series and you have, you know, even information from multiple platforms and multiple modality. I guess the question is, how would you be able to fuse and integrate, right, all these very different predictive signals to predict, you know, one target?
First off, I would say that like as much as you can reduce the number of inputs needed, the easier it would be for like maintenance of that model over time. Because like the more inputs that you have going in, the more likely it's going to be that something will change, that will change your performance and you'll have to go in and fix something. In terms of like fusing them all together, there are like a couple of answers that I could give. Like if you told me that you're going to use other kinds of data that's like imaging, and then you wanted to combine that with like tabular data, it can be quite challenging because like models might be easier to train for one or the other. And so the thing that I almost always lean on is some form of representation learning. But I'd say even before that, I'd be like, do I really need this input? Would be the question I would ask.
I see. The second question I have is that I think at some point you mentioned causation, and I think certainly I have a lot of hope for causal inference and causation in this kind of situations. But I guess one challenge that we run into in the past is the scalability issues for this classic methods for causal discovery, or maybe using this handwritten causal structural models. What are your thoughts about moving forward, right? I think at some point you mentioned that potentially we can look at representation learning and neural networks to help us to maybe reduce the dimension, or maybe help us to better model the interventional distribution. What are your thoughts, moving forward?
So for discovery, a lot of stuff I talked about was about conditional independence testing. And a lot of the discovery questions, if you have interventional data, is conditional independence testing. And so you could probably pair the stuff that I talked about to help do that. And there is work, I think, about like neural conditional independence testing, which is willing to make more assumptions than like traditional tests that can make things faster. On the other hand, when I think about like what the real challenges are, I come back to like challenges with the data. Like you're kind of going to accept every problem. You'll accept like selection bias, you'll have sampling frequency bias, you'll have like censoring, and you'll have confounding. And the fact that like if you want to do like even a singular causal inference problem where somebody has provided you with the structure, like what they think is the graph, then you'll still have to address all four of these issues. And that can be very, very challenging. And I would say that most of the issues and most of the challenges really rely on like trying to pick nice problems where they don't occur. But if we really want to see it like broadly applied, we're going to have to like figure out like methods that make it easier to address these things, and also to like check like what are the like how sensitive your results are to the assumptions that were made.
Thank you, Rajesh, for a wonderful presentation. Now we move on to the final part of our summit for today, and I would like to invite Daniel, Laura, and Ling to join us back in the session, and then we can start off with some questions myself. But again, we welcome any question from the audience, and feel free to put them in a Q&A function, and I'm happy to go over them. So I'll start off with one question I think Ling briefly mentioned in the beginning of today's lecture is how do we leverage AI techniques, for example, natural language processing to facilitate the interaction with patients, with the general public? How do we provide maybe incentives for vaccination? And I think certainly there are a lot of possible directions, right? For example, to understand the motivations of why people are hesitate about getting the vaccines or refuse to get in the vaccine. Do you think that we can do something with regard in collecting information along this line? And also, what are the things that we learned, right, for maybe the future?
I can take a stab at to begin. I mean, I think to some degree we're already doing this, and I think the question for me is who's the user that's receiving the output. So is the output designed for a health system to make decisions with regards to allocation of resources, clinic days and times, accessibility, information education, culturally or language appropriate information education. I think that's one subset of it. And I think the second perhaps is more the root of your question is what does this look like when the user is indeed actually the direct user is indeed the patient and the consumer themselves? And I honestly don't know enough about the latter to comment, but I'm really curious in the panelists' thoughts on it.
Any other comments about this topic?
I mean,
Yeah, go
I think
ahead.
the only thing that I'd add is that there's like, in the same way that like people in computer science have built tools to like summarize like, a bunch of text at the same time because you can't really like keep it all in your head at once. Those same kinds of tools should be useful if you have like conversational forms to summarize what's going on. And then they're not necessarily tell you like exactly how it's happening because you'll need to test those hypotheses. It's really a place for hypothesis generation.
Mm-hmm.
Right. And I think there's a very related question along this line is that I think was mentioned in Rajesh's talk earlier is that I think we learned a lot of lessons from the entire COVID-19 pandemic. And I think looking back, one of the things that is quite critical in the beginning is that we don't have enough, right, test kits to tell us the scope of the pandemic in March last year. I think, as I remember, we only get a significant amount of test kits towards the end of March last year, and maybe actually in April in the United States. So what do you think about some possibilities of preparing for the future? Because I think the same thing is going to happen, like Roger said, that we're trying to build models to predict it, but by the time this model is built, then it's probably not useful anymore. So are there any sensing mechanisms that we can use to basically better predict the onset of the pandemic? Or maybe there are some other tools that can allow us to do this. Rajesh, do you want to take a step on this?
Sure. I mean, it's a tough question because if you're asking me about like another pandemic and then like, are there tools that we can put in place that will surveil and tell you what's going on, then probably the only thing that would immediately come to my mind would be like, hey, are you seeing like localized network spreading of what's happening? But like doing that accurately, I don't know how to do yet, and maybe it is possible, but something like that could help if it was adopted enough and was like, correctly like validated, say.
The one thing that I would add for not necessarily about tools, but I think the mindset that we had during this pandemic, I think, having all those waivers in place to do these kind of studies definitely helped out. And I think at least from my institution, one of the experience that we learned was that because we had a positive experience of this, our center was able to clone the EMR, and that we know that if we had to recreate this, we could do it much faster for a different thing. In terms of being able to do it in real time, I don't think we're there yet, but I think the biggest thing was the mindset of having the administration and the end users say that, okay, we are bought into this now, we're gonna, give more permissions or more regulatory approvals to do this was the biggest help for us moving forward, I think. So I'm hoping a lot of those things stay in place.
And I think, I would agree entirely. And I think, I guess the question to me, I think, William, is you're not asking us what does the crystal ball say, the predictive crystal ball, but actually what does the crystal ball of the future even look like, and how to kind of how to build, should we have it ready to go essentially. And I think to piggyback off both of those comments, Daniel and Rajesh's comments, I think that I know our institution and many institutions, Daniel kind of is hinting at this, we're as things are winding down, as we no longer have 5 hours of meetings on COVID a day, but now down to maybe 2-3 times a week, and hopefully once a week soon, as things open up a bit, and our schedules open up a bit, we've actually started crisis planning and disaster planning going forward. And I think that machine learning and I think anticipating, well, we certainly don't know what the machine learning landscape is going to look like in 8 years' time or whenever the next one comes. I think having that be an important part of the conversation and the planning is critically important. I don't know that the problem is going to be in, again, I'm saying 8 years very arbitrarily. I don't know that in 8 years, the problem is going to be the 45-day delay in getting accurate diagnostic testing up and running at a scalable level across the US. But I know there was going to be a hurdle. And so the key is, I think, having the crystal ball ready to be employed as quickly as possible. And, the models are clearly part of that.
Yeah, I totally agree. I think models and tools are very important. But I think going back into our earlier discussion, I think a lot of the speakers today also mentioned that data sparsity is an issue, right? Whether in clinical trial or whether it is in designing some of these machine learning models. So that seems to be a great barrier for AI and machine learning to work and deal with this kind of situations. So I'm curious about your thoughts on the possibility of transfer learning, right? And maybe zero-shot learning by using the previous data, because the whole machine learning idea is that we can learn from the experience, right? And then we can predict in the future. Of course, there's all these issues about this, distribution shift that we mentioned, but in some other areas in AI, for example, we have observed some success of doing transfer learning to build more generic model, let's say understand natural language, and then we can, maybe fine tune this in downstream applications. That works well in some situations, some applications. I'm curious, for our COVID-19 related models, do you think they can be of any use in relating it into some other infectious disease? So I don't know if Laura want to start with some of the comments.
Yeah, I've actually seen a few of those in the systematic review for diagnosis and prognosis. So they started off with data not on COVID-19 patients. That's what they trained their algorithm on, and validated that and see with some minor tweaks whether they could improve much once COVID-19 data started coming in and could be used for learning. And actually the baseline models that didn't use the COVID-19 data already work pretty well. So I think these are interesting thought experiments or lessons for the future. And moving forward for that, from the traditional statistical diagnostic and prognostic modeling world, we know that updating models, which is kind of similar to transfer learning, I think, often works better than starting all over from nothing, because, you have less overfitting and it's more robust. So I think, that could be very useful.
I just want to add on for one thing for transfer learning. So we're trying to do a project right now with a nonprofit for exactly what you're talking about, William, for transfer learning. And one of the challenges that we have is the data inputs are labeled very differently. For example, our laboratory inputs are labeled differently. What we found early on is that they already had a model built on inputs that we weren't even recording. And so we had to figure out how do we deal with all that missing data. So I do believe that totally makes sense. It's just that it's hard when all the players involved, maybe our data is not homogenized the same way.
Yeah, put another way, I think when mechanisms are informative of mechanisms of data collection, which you don't really see in other areas of AI as often, like language or in collections of images, then rather than transfer, I sometimes think that it can be helpful in sort of ruling out information that would not be helpful in the longer term.
Great. I think certainly this is very valuable information. And I think in Laura's presentation, we also see a lot of interesting pros and cons of different machine learning models. And I think in Lin's talk, we also discussed the pitfalls of potential issues about trust and also about quality of various of machine learning models. So I'm curious about, in general, how do we probe and test, right, this machine learning models before we deploy them, right? So I think there are a lot of discussions yesterday at FDA, how they do this different tests. And I think there are many discussions at other different federal agencies, including FTC, on, how can we, design mechanisms to test different properties of these kind of machine learning models, for example, fairness, and before we deploy them. So I guess the question for the panel is, how would you summarize the key properties that we should test, right, before we deploy this machine learning model?
Well, I think you need to, probably it's a very basic answer, but I always see it in two steps. First, you need to test whether your model is predicting what it's claiming to be predicting in unseen data. And that's something completely different from evaluating the impact of a model when you use it in clinical practice. As Rajesh very clearly pointed out, when a clinician starts interacting with a machine learning model, all sorts of things can happen. And that can change over time. So I really want to keep those two separate.
And I think I would add that, again, the clinician's perspective, I think I look to trustworthy experts to vet tools as they come down the pipeline. But I also know that our field is prone to new technologies, new tools, new medications, new therapeutics that are approved for one purpose, bleeding across the field and being utilized in different ways for which they weren't originally intended and rigorously, tested, right? And so I think that that's just another lesson learned from eons of clinical practice that I think I worry about. So again, not just the onset of the approval, and again making sure that gate is robust and the hurdle is high enough, but also that there is some downstream opportunity for certainly opening the door for how these tools can be flexed and pivoted within clinical practice in a way that they weren't originally tested. So not too constrictive, but at the same time, making sure that there are some checks and balances in place to make sure, again, that they're not being applied in ways that they ought not to be.
And then, if I may elaborate on that.
Yeah, go ahead.
In the Netherlands, we've had with the government some discussions on who then would be responsible for that, or with a thought panel instilled by the government. And is that the responsibility of the hospital who's utilizing it? Is it the responsibility of the one selling the algorithm? Does he need to collect that data? So I really want to ask the panel's opinions on that.
Yeah, I mean, the thing that I might say that's somewhat related to that is that, like, it's already happening in a way under the guise of quality improvement, like a lot of individual institutions. So I wonder how these individual institutions deal with, like, who is responsible for what and the maintenance of what, when it's like a interaction between a large group of people, like me on the end of like methodology development, people who process the data, and users of it.
Yeah, I'll just add that my concern, again, extrapolating from from non-machine learning tools, but just from clinical tools that we use, I think that Laura's point is perhaps the most, it's what I would be most concerned about, which is, again, being cautious to avoid those who are profiting from the tool from also being the regulator and the policeman, and just the dangers that are inherent in that approach.
So I agree with everything said. And I think the last thing I would just add on to that is, when you have like a tool where the benefits are uncertain, but there's a low utilization cost, you end up just, that's what's a trigger for overutilization. So I'm a radiologist, and anytime you have a tool or solution that the barrier to use is low and the benefits are unproven, more often than not, clinicians are going to use it because of a supplier-induced demand. And that's not necessarily what we want. And I actually have a question for the rest of the panelists. One of the struggles I had during this period that would have been helpful is to be able to do a more randomized controlled trial or a clinical trial. But at the time, our institution didn't have any appetite to do that because it was during the COVID pandemic. And now we're kind of used to this, and it's kind of, once you give it to clinician, it's hard to say, okay, we're going to randomize it. So I don't know if there's any advice or guidance for, because I think that's what we need, is we need to actually have these studies to show, do these actually make a clinical benefit? I think we've demonstrated that these models work, but does it actually make a clinical benefit? I think that's where we still aren't 100% certain.
I think that the patient protection, laws are obviously very, very important, but they end up often, leading to barriers, hurdles, and cumbersome administrative just processes, including, I say as, a member of our local IRB vice chair right now, previously the chair, the processes are slow and are not well set up to be able to provide the answers for a prospective clinical trial in a way that I think is going to be highly efficient. And I think what that means is, I think, two opportunities. The first, I think, Daniel, this is your point, is that we need to modernize that and update that as much as we possibly can, while still being clear that we're protecting our patients. But I think secondly, thinking of creative ways to try to, again, I think an RCT is, what we've all learned is the best gold standard set of evidence. But I think it's also okay to question that and to say, is that really true? Is that a truth? Is there other evidence that we are increasingly comfortable that we can rely on that's either a modified RCT or some other, utilization, again, perhaps of more sophisticated, techniques to try to give us some of the answers free of bias. So yeah, but I think ultimately I just I sympathize and empathize.
The thing that I'll add to that is, like, going across multiple institutions makes it even harder, but feels necessary to do it here.
Yeah. Yeah.
Great. My final question for the panel is that I think I'll start off with maybe Daniel or Rajesh. I think we can continue this discussion is what are the most important lessons from our deployed models, right? So if you were to start over again, what would be the things that you want to change, right, to actually make this model better? So I don't know if Daniel or Rajesh want to start first.
I can start. There's two things maybe that come to mind is, like, one is, like, if there was like better data provenance up front, it would have simplified a lot of what was going on. Laura mentioned that a little bit. And some of the things that we had to like chase down and slowed us down was like, where is this coming from? Why is this 0 all the time? That happened more than once. The second thing is, like, to not undervalue the use case of teaching or learning that doctors can do from like what the model says, because like there are like inputs and they do see what happens, and then a lot of the positive feedback that like clinicians like verbally provided was on like, hey, like there was so many different things going on, this helped me like really focus, and then like I had a little bit more faith that I should focus on it, both from seeing what I saw from the actual patients and from the fact that it was like prospectively just validated over 2 periods. I think those, like, that was probably something that I undervalued at the start that I should have valued more.
I think one of the things that was challenging for us that we eventually kind of got towards, but hadn't fully, is really, we talked about engaging the stakeholders, and we had engaged a lot of the department chairs, but really finding ways to do town halls to start engaging the doctors and residents who are actually using these tools. And because I can't remember which speaker said it, but one of the options is they just might not use the tool. and then figuring out what is the barrier to you using the tool, what is it that you care about, how can we alleviate it? Because if you use a tool and no one uses it, then you're kind of spinning your wheels. So I think that's something that we could have improved on.
Thank you. Thank you. I mean, that really reminded me the question I should ask maybe earlier, and that is really engagement and trust, right? I think this was also brought up in Lynn's earlier discussion. So of course, I think every one of us, when we see some new tools, when we see some new AI techniques, how well can we receive them, right? And then how long does it take for us to receive them, right? So I think, I don't know if Lynn or Laura can give us some maybe comments on how we can better facilitate the engagement with the users, and I think actually multiple users, right? So different users of this kind of systems.
Yeah, can I take this question in? Yeah. Well, of course, Lynn has a medical background, so I'd love to hear her thoughts on this. But well, the first part of your question reminded me of an implementation, well, sort of trial, pre-post trial of a risk stratification model for pregnancy-related care that we did in the Netherlands, or my colleagues did. And what you could see there, we monitored use over time. While we were doing the trial. So we started off to a really low level, and then as time progressed, people started trusting it and using it. But it never got above 80%. But what was really interesting was, we needed a year or something to reach that 80%. So it took a while to get clinicians and the stakeholders on board. But then at one time, the system was down, so they couldn't access it. And immediately, they started contacting the investigators. What's this? We have a patient. We need this tool. So it takes a while, but once I think they see the use. There's how do you say that in English? Well, they're hesitant at first, but maybe that's because they don't know what they've missed. And then the second part of your question was, well, how can we improve the trust in these scores? Well, I think there's two answers to this question. I think we have to earn that trust. If I look at my literature review that I've done, I think we need to step up our game. I think we have to do those external validations, make sure we document clearly what we've done, what the patients were, so we have to be more transparent than a lot of us are at this moment. Then the second part is that we've seen this cycle before with other evidence-based medicine tools, so other electronic decision support that wasn't necessarily AI-based, but also electronic decision support, or also evidence-based medicine support systems. And what you saw there was that and this is closely connected to what Rajesh said earlier, that it was very hard to demonstrate. If you look at the systematic reviews of those systems, it's very rare to be able to demonstrate better patient outcomes. And one of the reasons was that clinicians weren't adhering to it. Well, I looked into that literature a bit, and a few of the tricks that worked is actually to ask for reasons if they don't comply. So a warning pops up, and the clinician has to fill into the patient file why he or she is not complying with the recommendation that was given, and that made a big difference. That's hard. I mean, that's well, I don't know what doctors would think of it, but that's one thing. The other thing is targeting patients and doctors simultaneously in a shared decision-making context. That also seems to work. So you provide the output of the algorithm not only to the doctor, but also to the patient. Now, that's not for every disease, but if it's, well, prognosis, or which medication or which type of operation do you need, if it's decision support for that, and you couple it to recommendations for the patient, if the doctor then has to explain why he's following it or not, or discuss it with the patient, adherence seemed to be a little bit better. So those are a few insights that I've gained over the years.
Oh, so interesting. I think agree with so much of that, all of it. I think just a couple of thoughts. First, I think that at the leading edge of a crisis, unfortunately, is just never going to be the time for novel approaches. And so I think the opportunity now, before the next crisis, is is to build trust, to build to build experience with these tools. And I'm optimistic that that's what's going to happen. I think the second is just speaking as a clinician. I think that you all get the mile high view from a population level perspective, Rashesh, or from a CS model perspective. But I think what you have to remember is that the clinician standing in front of one patient is focused on the outcome for that one patient. With that comes, I think, to a person, I hope, a desire to do the right thing and to help this person, but also comes all the baggage of their own experience, their own anecdotes, and their own bias, and their own everything else. So I think that the low-hanging fruit for me, the opportunities, and this isn't rocket science, but it's just intuitive, is that I think that the opportunities are in the places that clinicians already feel discomfort, where they already are looking for a prop. They're already looking for I like Laura's approach. I couldn't agree with you more. I think you can wear them down with pop-ups, right? You just keep giving them pop-ups to click through and click through and click through. Sometimes our heads explode, but I think you're right to remind us, you are deviating from evidence-based practice and why, and just to make it clear and give. And I think, if some small percent of the time it's beneficial, then then you win. But I think really looking for those opportunities in large part through good translational interactions like this one, where those of us on the clinical side of the street talk to those of you who are in this expert field, and really find, again, what I call the low-hanging fruit, where there are going to be opportunities that are going to be more easily adoptable, with bigger uptake, in a time that is not crisis, and I think from there the sky's the limit.
Thank you. I think Lynn has a wonderful conclusion to today's panel, and we're just running on time at noon here in Santa Barbara. And so I would like to thank all of the panelists and speakers today. I want to thank Rajesh, Laura, Lynn, and Daniel. Daniel has to leave slightly earlier due to family issues, but again, I think very enlightening discussions and also presentations this morning. Also want to thank all other speakers for the virtual summit for all 3 days. Want to thank Duncan, Susan Mellenchamp for sponsoring this event. Also the various centers, Cottage Health, for providing help in organizing this event. Finally, I want to thank the event co-organizers, Maria Napoli, Laura Langen, Miguel Exting, for organizing this event. And we hope to see you next year again, and hope to meet you in person for the next occasion. And thank you again, everyone, for attending, and see you next year.